whakarau I ke mai nei rungi te karanga o tēnei kaupapa, te ata nei, me ngā rā I mui a tātou, mihana ki a koutou katoa. Huri au, ki tō tātou reo, o tōku tupuna John Manford Steedman, haka mara mai a tātou katoa. Morning everyone. I just said that I'm going to turn to the language of my ancestor John Manford Steedman from Perth in Scotland to explain what's about to happen first, and then I'm going to return back into Te Reo Māori to go through our official and traditional processes of welcoming everyone appropriately here. Ka nohi e koutou katoa, those of you sitting at home or in your offices or in the car on the way to work watching the live stream this morning. Be careful if you're doing that third one. So I'll also go through a bit of an explanation too around the things that I've noted in my opening address, and then afterwards we have a group fully prepared, separated into singing parts to sing our tautoko waiata. If you know the words, this is for all of us, so please join in when we get to that point. Hoi anō, mihi ana ki a tātou katoa, me tīmata. Tērā ia te māturanga te pākuru mai nei huru tau he ruru atu. He ruru tawhito ke e nei pūkinga ke e nei wānanga. Ke ai te tohinga anuku te tohinga arangi ki te wai o tuo ki te wai whakaikio ko te wai te tauira. He wai tapu, he wai nui, he wai oro oi. Ka pepe, ka wawai, ka poru tū te mokopu taurarangi e hera ki te he tupua. Ka puta ki te whaiao, puta ki te ao marama, whanno, tau mai te mauri. Haumi e, hui e, tā ki e. He aha te hau e wawara. He tiu he raki. Nāna ia mai te puputara ki he kiota. E tiki nātu au te kōtiu ko I te pauwhakairo ka tū ki te wai te mata I oku wairangi e. E ti he wai mauri ora. Iaku nui, iaku rahi, koutou katoa ngā mātā waka. Toia mai, rungi te karanga o tēnei whare, o tēnei wānanga o tātou, waipapa taumatarau. Nau mai, hara mai, whakatau mai. Nau mai I runga te karanga o tēnei kaupapa, te mate I ngā pukapuka, roti I ngā tangata puta noa ki te ao, nau mai. Hara mai ki te karanga o tēnei whare, I roti te mātauranga hauora. Me ona mātauranga katoa, kohi ngā ngei I roti tēnei whare. Whakatau mai I roti te reo, Ngāti Whātua Rākei, tū ake nei ki te tuku ngā mihi ki a koutou katoa, tēnā koutou katoa. A tuatahi ki ngā tini whakapono o wainga nui a tātou, he whai he arawarangi Māori e runga ngā tini kaupapa, I runga o koutou pukahiwi, mihi ana ki a koutou. Huri taku whakaro ki te kāinga tawhitoa pota tau te whero o te tuatahi, I roti te waikohanga me tōna mokopuna te kingi tū heitia, I ona manakitanga katoa e noho ana I te ahurewa tapu e mihi ki aia. Ki ngā tini mate, huhoa te wā, I runga o koutou manawa, I roti o koutou pukahiwi hoki, ki ngā mate katoa, e here mai nei, I rungi te whakaaro kotahi, e ngā mate haere atura. Rātou kia rātou, e noho ki reira, mene mai nei, ki a mātou, ngā mōruhutanga, a tātou ki a tātou, te hunga ora, noho ki tēnei whare, a tēnā koutou katoa. Nō ku te whiwhi, mai te taha waipapa taumatarau, ki tēnei whare, me enei ngā kaimanaki, ngā upoko o tēnei kaupapa, Asthma, ki te mihi atu ki a koutou, mai te taha o te PVC Māori, te Kauahau Hoskins, mai te taha o aku mātua tupuna hoki no tēnei whenua, I roti tērā āhuatanga o Ngāti Whātua Rākei, e mihi ana. Ki ngā kaiwhakarite, Innes, Judith, me tō tira whakahaere, te whakarite o whakatū tēnei kaupapa mō tātou, aku mihi nui ki a koutou. Me ngā manuhiri no tāwahi, Āwhiraka ki te Tonga, Liverpool, tēnā kōrua, koutou katoa, I rungi I te ipurangi hoki, mihi ana I rungi te aroha mō tō tātou kaupapa I te rānei. Nā reira, taku hia ki te huri, Ki te reo, a tōku tupuna anō, John Manford Steedman, hakamara mai tātakau, katoa, tēnā koutou, tēnā koutou, tēnā koutou katoa. Morning again. It is my privilege to offer these words of welcome in a few different contexts, and I'll go through each of these. But we acknowledge you all as mā tā waka, from the various waka that are tethered here symbolically to this pole or this pou of a building here, which collects all of the various sets of expertise for the benefit of the rest of us across this country and across the world hoki. And so with that, we acknowledge our international visitors and viewers. It's always a pleasure to connect ancestor ki te ancestor and to the rest of us here in this space too. I stand here not only as Deputy Pro-Vice Chancellor Māori, but I stand here also as Ngāti Whātua Ōrākei, the tangata whenua of this particular space. And so I stand here on behalf of my ancestors to make sure that our ancestors get the opportunity to meet one another through each of us today. And so it's very important that we offer that sort of acknowledgement so that we can connect you directly to the space whilst you're here under the auspices of this particular kaupapa. One that's dear to my heart, or should I say lungs, as a asthma sufferer or a person with asthma for all of my life, and I always tap my pockets to see if I've got my Respiratory or salbutamol or Ventolin, but I don't, but I know where it is. And I know who I can call upon if I should get in trouble. In fact, this is the best place for a person to be at this time. So I acknowledge you personally on my behalf and members of my family that carry this particular disease, and acknowledge the importance of the work that you do. And I was talking to Ines before around me as a person with asthma, dealing with asthma complacency. And just, I've got asthma, I know what to do, I'm not going to think any further beyond that. And so that you guys are gathered, and there's new information, better ways of care in terms of people dealing with people like me. I think there's many great reasons that support the gathering of you all here today. So I stand here also on behalf of the PVC Māori, also on behalf of the Vice Chancellor's Office, and so I just want to pay special acknowledgement to you, Ines, for reaching out, for enabling me to be a small part of today's gathering. I want to acknowledge your team, Judith. I want to acknowledge the role that you have in all of this work here, and in particular acknowledge our international visitors, and hope that you find the hospitality of this place to your expectations. And the weather's been pretty good the last few days, so hopefully you get a little bit more of that over this time, and obviously the multi-course banquets that are come at the end of this conference. I'm just assuming that's going to happen. But yeah, welcome, welcome, welcome on behalf of my ancestors, to all of your ancestors, to noho pai, I rungi te rangi Māori, I rungi te wānanga hoki. So the last word I use there is wānanga. Wānanga is appropriate to a place like this because it's a gathering of ideas and of knowledge sets. And you sit together, you collaborate, you butt heads if you need to, but with an underpinning set of values around respect and integrity, and acknowledging each other as what we call mana, your own personal integrity. So wishing you all the best in that regard for this particular gathering, and for myself as a person with asthma. Mihi ana kia koutou katoa. Thank you so much for what you do on all of our behalves. Kanawhe tēnā mōku, which is another saying from here, which means that's enough from me. Mihi ana kia koutou, so I'm going to ask our choir to come forward and sing our waiata. So again, if you know this song, please feel free to join in. Ka pai, so yeah, we'll get everyone to stand. Just make sure we're not in front of the camera.
Te aroha, te whakapono, me te rangi Māori e tātou e. Te aroha, te whakapono,
hea te mea nui o te ao, he tangata, he tangata, he tangata. The last proverb, whakatauki, talks about what's the most important thing in the world. Tis people, tis people, tis people, and through that we acknowledge the opportunity to gather together and share ideas. So I'll leave you with that. E mihi ana kia koutou katoa. A tēnā koutou, a tēnā koutou, a tēnā koutou katoa. Kia ora.
Thank you very much.
Thank you very much for that really warm welcome. My name is Rifula Masekela. I'm the GAN co-chair with my colleague, Professor Kevin Motuma. My job here today is to welcome everybody to this wonderful symposium and really to thank Ines, Philippa, Eamon for the warm welcome in Auckland. We really had a wonderful 3 days, very busy, but really have had a really fantastic time in a beautiful city. Just some housekeeping rules for those who need the facilities. I think once you get out of the door, it's to the right-hand side. What we're going to be doing today is a little bit different. You'll see that the timing of our talks is fairly compact. We will not be having any QA sessions after any talks. So if you have any questions, please, we're all approachable. Just join us during tea or lunch if you have any questions. But what we do have for the symposium, which is slightly different, is we will have, post the symposium, we have what we call a smart lab. You will be getting a login and password, so you'll be able to engage with the speakers, engage with other people with interest. You can join us on the Smart Lab, and if you have any questions or any discussions, or most importantly, any suggestions for us, you'll have access to that Smart Lab. It will be open in February. You'll get those details. And also, secondly, I will not be having very long introductions to all the speakers. We will not do that. We'll just have brief bios of everybody. They're all also on the website. You're welcome to see a little bit more about the speakers. So I think, in short, just so that we can move on, I'm going to introduce our the second speaker, is Professor Judith McCall. She is the head of School of Public Health, and here she's an expert in public health, and I've just had a brief look at her work. She's interested in what we find very important in the asthma world, is tobacco control. So really, thank you very much for joining us this morning, and I'm going to let us, Prof. McCall, give us a welcome.
Can you hear me okay if I just speak from here? Is that okay? All right, and I will just pour some glass of water. Well, tēnā koutou, kia ora koutou. Ko Judith McCall, te kawengoa. No mai, haere mai, and welcome everyone to Waipapa Te Mātarau and to the School of Population Health, or the Faculty of Medical and Health Sciences. We are all absolutely delighted to be hosting the Global Asthma Network Symposium 2024. I just want to make a note right now that I don't normally write notes before I give a speech. I'm a little bit ad hoc, off the cuff, but because of the importance of this event and the eminence of the speakers in the room here, I felt it was important to write just a few notes. So firstly, I'd like to start by thanking Professor Ines Asher for offering me the opportunity to speak, to welcome you all here. I'm really truly honoured. To me, when I received the invitation, Ines, I was absolutely delighted and did feel genuinely really like, oh my word, how can I do this? This is a really important piece of work with extraordinary people who will be in the room. But I want to pay tribute to you all as esteemed, dedicated and committed leaders in global asthma prevention and treatment. I'd like to thank the organisers of this event, and particularly I acknowledge and thank, and I'll speak more to later, of the work of Philippa Elwood. But Philippa and I had a bit of a chat before we started this morning, and she spoke of this huge team that stands behind us that we don't see in the room this morning. And that is the team that providing the catering, who've organised all of these events. And the funders for this event, I understand that University of Auckland and the Wellcome Trust have provided funding. Correct me if I'm wrong here, Innes. And similarly, I'd really like to thank everyone for travelling. This is, coming to New Zealand is no easy task. It's a long way to come, long hours in the plane. So really grateful for everyone making the time, and even people who've come from across the road here. We know how busy our lives are, so to actually dedicate and block out time for this work, for this talanoa, for these conversations is incredibly important. In the preparation for this brief address, and it will be brief, I was drawn to this extraordinary story that provides the context and the purpose and meaning for this gathering today. It's a story that reflects a vision, or the vision and the dogged determination of a small group, a relatively small group of clinicians, researchers, coordinators, many of whom are in the room this morning, that made a decision some 20 years ago to prioritise asthma health equity. They might not have used the term health equity at the time. It's certainly shifted and become very much a priority for us all. But they decided to work together to generate and create a more complete and complex description, a mapping of and patterning of the differences, the nuances and detailing of asthma amongst children and adults, not just within countries, but between countries, and particularly focusing on low and middle income countries, which have been typically left off the map. At the time, as you know, global asthma data was predominantly focused on just a few countries, predominantly all high-income countries. So this was a game changer, to focus resourcing and efforts in a coordinated way to look at what was happening in countries with lower resources. So the International Study of Asthma and Allergies in Children, ISAAC, was established in 1991. Innes will cover the detail of this. And this work was groundbreaking, not only just to the respect to the rigour of the research methods, but the focus on data sovereignty and having locally and country-led research. Absolutely essential. In my readings of the background of this work, what struck me so clearly, was the group recognised, again, ahead of their time, that they needed to think and act as a network of collaborators with a shared vision and a purpose. The Global Asthma Network, subsequently established in 2012, collaboration between ISAAC and the Union for Tuberculosis and Lung Disease, thereafter the Union, established and coordinated this network of individuals who prioritise action and impact over ego, to ensure that the fine, detailed, nuanced work of coordinating multidisciplinary, multi-site research was conducted to high standard. This is not easy work. Last week I was in the Cook Islands. I was there for a week, working with colleagues in the Cook Islands, a island grouping in the Polynesia sub-region of the Pacific. I was there with colleagues from the Centre for Pacific and Global Health, which I'm one of the co-directors, and Te Marae Ora, which is the Cook Islands Ministry of Health, and met with local NGOs to talk about cancer control, what was in place, what they'd like to have, and what their aspirations were to improve cancer outcomes from early detection screening to palliative care. The theme that cut through all of these talanoa, these conversations, these meetings we had with everyone on the islands, both in the Paenua, which is the outer islands, and Rarotonga, the main island, was the importance of effective communication. It seems so simple. That there were systems in place and that they're complex, but they can be adaptive. And what also stayed with me was the extraordinary impact that a small group of committed individuals can have when they work together as one, each respecting the importance of the work of the other, particularly in the multidisciplinary context, but each pulling their own weight. And during the week we visited Atutaki, it's one of the outer islands of the Paenua, a remote by 50 minutes flight, one of the closer islands to the main island of Rarotonga, renowned for its exquisite beauty. During our time on the island, we met a group of, and I have to say it, predominantly women, actually exclusively women, I'll be honest, who run the entire health system. Public health, primary care, screening, secondary care, referrals, palliative care. The nurses deliver babies and they look after people when they die. They were a force, each knowing where they fit in the system, how they contribute to the whole, how to communicate with each other, how to step in when someone's not able to pick it up. They had a clear purpose, and that was to elevate the health of their population, to put health in the foreground, and to protect the lives of their community, essentially. We certainly are clear, and it's said very, very often, that global impacts are certainly and absolutely fueled by local actions. So today's another significant event, a punctuation in the storyline of the Global Asthma Network. And as I read through the biographies of the speakers that you're about to hear from throughout the next 2 days, oh my word, I was absolutely blown away by the calibre of the people in this room. And I acknowledge our international guests and our local contributors over many, many, many years. It's a story full of extraordinary, committed, talented and generous people. The program ahead is a day of who's who in global asthma research, and we are absolutely privileged to be hosting such an event. Finally, I would like to acknowledge again and thank all the speakers and the audience. In particular, I want to again pay tribute to Philippa Elwood, who I understand is a core character in this story, who has been a central person to this network, who I am absolutely delighted to have met this morning. And I feel very honoured to have met you and having read so much about your work and heard about you and what you've done alongside your very good friend and colleague, Ines. It's really significant, and all I can say is what an extraordinary and fulfilling career you must have had. So we look ahead to the 2025 high-level meeting on NCDs, major event in the global health calendar. We've got work to do. We've got to get ready for that. We have to make most of these opportunities where we can have an impact. We need to hit it really hard about what we need to make a difference for cancer. Asthma. Cancer's right. So the value of the network has collectively achieved in generating global asthma surveillance is acutely important. I met our colleague here this morning who's central to the data. We know how important all of these pieces are in making an impact. So finally, again, acknowledging all of our colleagues in the room, Professor Ines Asher, Matua Steedman, and everyone who's brought this event together. I understand you've been working all weekend and it continues, but I do hope that you can get time to enjoy the beautiful Aotearoa and Tamaki Makaurau while you're here. It is an exquisite piece of countryside and a wonderful place to be. With that, I really just want to welcome again and open the session and say ngā mihi nui to everyone in the room. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Thank you.
Thank you very, very much for that really warm welcome, and thank you to Professor McCool for that welcome to Auckland, and we really appreciate you having us here. Thank you. I think my next job is probably going to be the most difficult one, because Professor Ines Asher is a force to be reckoned with. I think probably well known to all of us in the room. Anybody who doesn't know her, they're in the wrong place. Ines is an emeritus professor of this university, and she was actually the head of the pediatrics department. But the first time I obviously saw Professor Asher's work was with the ISAAC studies. So when I actually met her for the first time, you can imagine I was gobsmacked. This amazing person who's done this amazing work. And the one thing about Ines is she's kind. She's really one of the kindest people I know. And I think having chaired this really amazing network of over 130 countries for over 30 years, you can see why when she had to be replaced, they had to get 2 people. It was impossible for anybody to replace Ines because not only is she an immense and wonderful researcher, she has an acute mind and she's absolutely kind and treats everybody with kindness and respect, and I really appreciate that about her. So, as you've heard before, she chaired the ISAAC studies from 1992 to 2012, and then when the GAN network was started, she also chaired it through till 2022. So it's really only a great pleasure for me to introduce Ines, who's going to be telling us about the ISAAC story, which I think is the correct thing to do because she's been there from the beginning. So thank you very much, Ines.
I'll get water. You each get my card. Tēnā koutou katoa. Thank you very much, Professor McCool and Professor Masekela, for your very kind words. I feel very honoured and privileged and humbled to have been involved with these 2 remarkable research programs over more than 30 years. Why did we establish ISAAC in 1991? Because of concern that asthma, rhinitis and eczema were increasing and that the causes of these increases were unknown. We're going to focus just mainly on asthma today and not go into any depth on the other diseases apart from Dr. Sapsford's talk on eczema. Most previous asthma research had looked within populations at why some individuals rather than others develop these diseases. There were few between population studies. Most of the world was unstudied, especially low and middle income countries. LMICs. In 1991, few centres, this illustrates that few centres had information on population prevalence of asthma symptoms in children using inconsistent methodology and few LMICs. In the middle of this map, you'll see a square which is an expanded map of Europe, which is needed to hold the high number of centres we had in ISAAC. So 20 years later, in 2011, the ISAAC network had 306 research centres in 105 countries, most LMICs. What were the unique principles of ISAAC which led to this success? It was collaborative, multi-centre, involving all regions of the world, cross-sectional study design. We studied populations of children in school, 3,000 per age group to have enough power to detect differences in severity of asthma. 2 age groups, 13 to 14 were compulsory and 6 and 7 years optional. It was protocol-based with simple standardised methodologies and questionnaires. It was relatively low-cost research, which enabled LMICs and emerging researchers to take part. We had central checks of methodology and data and analyses. Individual centre communication was needed often. Each centre owns their own data, and all investigators are authors on worldwide papers. Now, these same principles have been carried through and adhered to in GAN, the Global Asthma Network. What was the ISAAC program? On your right, you'll see dates, and these are the dates of the data collection. ISAAC Phase 1 was worldwide prevalence and severity using questionnaires, and then ecological analyses with Phase 1 data. ISAAC Phase 2 was different methodology, and we won't be discussing that today. ISAAC Phase 3 was a repetition of Phase 1, enabling time trends in asthma. It also enabled addition of more centres, meaning a larger world map. We also added the environmental questionnaire with risk factors. What did ISAAC find? Asthma occurred everywhere in the world. Asthma was more common than was thought. There were large variations in prevalence by centre. Asthma overall was increasing. Increases were more common in LMICs, where asthma was more commonly severe and association of asthma with atopy was weak. Many potential risk and preventive factors required further exploration. Why did ISAAC wind up in 2011? It was because of lack of funding. There is no funding body for global asthma research. However, the first United Nations Summit on Non-Communicable Diseases, NCDs, in 2011 created a new impetus and opportunity which led to the formation of GAN. Why did the UN hold the first summit on NCDs in 2011? It's because NCDs cause most deaths in the world. 80% of NCD deaths occur in LMICs, where 84% of the world's population live. Which were the first NCDs addressed by the UN? Cancer, heart disease and stroke, diabetes and lung diseases, COPD and asthma. Subsequently, the UN NCD initiative is now focusing on other diseases as well. What were the big concerns about asthma? Concerns about asthma deaths. These are as common as malaria deaths, more than 1,200 per day. In this graph, you'll see in the top group is the high-income countries, mortality in high-income countries, and the lower group, LMICs. Much greater death rate in LMICs where we have the data. But that's because in LMICs, effective asthma management is sometimes non-existent or inaccessible. Concerns about disability due to poor asthma control. This graph here shows disability by age group, and that disability is more common in older children and adolescents and in adults over 50. Concerns about the economic impact of asthma. Children miss school or preschool. Adults can't work. Many adults don't work effectively. Serious loss of productivity. Uncontrolled asthma costs are huge. Concerns that many people cannot access essential asthma medicines. This includes the availability of medicines, accessibility of medicines, pricing of medicines, quality of medicines, and we'll be hearing a lot more about this later in the program today. As I've said, the United Nations high-level meeting occurred as ISAAC was winding up. Because of the high-level meeting, Dr. Neil Spilo of the Union approached ISAAC to produce the Global Asthma Report for this meeting, which we did. A very successful collaboration between ISAAC and the Union. And subsequently, the Global Asthma Network was established in 2012. This GAN steering group includes some expert members from the ISAAC Steering Committee to continue the ISAAC network's work, and from the Union, experts from the Union to continue their LMIC work through their networks, especially the Asthma Drug Facility, ADF. Significant funding for the Global Asthma Network came from the Union, through the Executive Director, Dr. Neil Spilo. So why was GAN established? To continue to work towards reducing the burden of asthma in the world. To undertake surveillance using ISAAC methodology to study time trends in asthma, children and adolescents. To survey adults, because there was no adult prevalence data for asthma since the WHO survey in 2003. To undertake other research, including online surveys on national strategies, guidelines and medicines. And to strive to improve access to affordable, quality-assured essential asthma medicines and advocacy. The GAN network in 2023 has 387 centres in 138 countries, most LMICs. This shows those who completed phase 1 in red, and the others are other collaborating centres taking part in other ways like the online surveys, as well as the other ones. So a key advocacy tool of GAN has been to produce global asthma reports. We produced one in 2014 and another in 2018 to coincide and to be launched at the subsequent follow-up UN meetings, high-level meetings on NCDs. And the Global Asthma Report 2022 was an opportunity to bring a real update on the burden of asthma in the world by presenting results from the Global Asthma Network Phase 1. The contents of the Global Asthma Report 2022, there's 102 pages, 18 chapters written by 97 authors from 31 countries around the world. The forwards by Dr. Bente Mikkelsen, Director, NCD's Department, WHO. We're very grateful for their support. There are 3 main sections: the burden of asthma, asthma in the WHO regions, improving asthma management. What have we learnt about guiding principles for successful international collaborations? The key factors are relationships and processes. Respect, honesty, integrity, commitment, trust, transparent, fair, reflective and dynamic. Decision-making by consensus rather than vote. Conflicts are discussed and resolved face-to-face rather than by email. Early development of a publication policy and plan which is adhered to. Regular group meetings, phone or video conferences or in person. A small executive with very frequent communication. All decisions need the support of the whole group. Collective ownership, and importantly, the collaboration is of greater importance than aspirations of individuals. I'm finishing with thank yous. Thank you to everyone involved in ISAAC and GAN, especially Philippa Elwood, who's been an ISAAC and GAN steering group member, for her sustained research leadership and extraordinarily effective engagement with the collaborators and networks of ISAAC and GAN. Thank you, Philippa. And thank you to everyone else involved in ISAAC and GAN, other members of the GAN steering group, past and the present members are listed here, the ISAAC steering committee members, children and parents who participated in ISAAC and GAN and school staff, principal investigators and their colleagues. Thank you to funders supporting ISAAC and GAN, the many funding bodies throughout the world that supported the individual ISAAC centres and collaborations and global asthma reports. Funding bodies supporting the Data Centre, Global Centre and GAN Data Centres. And special thanks to the University of Auckland, Waipapa Taumatarau. Thank you.
Thank you very much for the ISAAC story to Professor Asher.
Oh, sorry.
So our next presentation, it will not be an in-person presentation. It will be by Dr. Sonia Fulaki. So this is a recorded presentation. Dr. Sonia is from the University of Wellington, from Mercy University. He was one of the studies in the Pacific Islands, and he has a special interest in asthma in the Pacific Islands, both in the islands as well as in New Zealand. We will start his presentation. Thank you.
Poliaki. I'm from Tonga and working as a research fellow at the Research Center for Health and Health for Mass University's Wellington campus. Thank you for your time and presence for this brief presentation. I'm sure the majority of you are familiar with the ISAAC study, but may or may not be aware that the ISAAC study was in fact conducted in the Pacific, involving 8 countries. The landscape and population, as you can see from the slide, is range from those in the photo, and populations ranging from a few hundred to almost 1 million. Still, not large by world standards, of course, but it gives you a picture of ISAAC in the Pacific. As you realize, ISAAC was carried out worldwide, globally in fact, and I'm told it was carried out in areas where there was a war going on. But the Pacific came in among the late countries to participate. The sum operational shown in this slide, I think the message is that understanding asthma prevalence that is valuable in assessing management approaches, research, and comparable to other countries and trends within countries, facilitating management and learning from other countries' experiences. But at the outset, it must be remembered that some of the countries participating are fairly small in population and should be acknowledged in the interpretation of the results. Also, as pointed out, there's considerable variation in asthma symptoms prevalence across the Pacific. In addition, the prevalence is very much lower than in similar studies of asthma among New Zealand, Maori, Pacific and Europeans, which brings the question of environment to the forefront with regard to asthma. As you all know, the Global Asthma Network is a collaboration between ISAAC and the Union Against Tuberculosis and Lung Disease. This brief presentation, on the other hand, focuses primarily on the trends and difference in asthma prevalence among Pacific, Maori and Europeans in New Zealand. As mentioned earlier, this presentation focuses on GAN phase 1. We have reviewed the data from GAN phase 1 in New Zealand and a trends analysis comparing ISAAC 1 and ISAAC 3. And our focus has been on the analysis of 7 variables, not all, from the ISAAC studies in New Zealand, primarily on 7 variables. As asthma ever, wheezes in the last 12 months and others that would come to light later on in the presentation. What our first study has done in looking at differences in certain asthma symptoms markers is that by Pettimore, which selected findings in the table. As you see clearly, the percentages among Maori, Pacific and Europeans. This is of course among children 6 to 7-year-olds and 10 to 14-year-olds. What needs to be reminded is some of the questioners, 6 to 7-year-olds with videos or helped by parents, whereas the 13 and 14-year-olds were basically written questionnaires which they can, 13 and 14-year-olds could answer. Follow-up study by Allison in 2009, finding that ethnic differences in asthma symptoms prevalence in New Zealand have increased, suggesting inequalities in access to healthcare and certain instances where there's probably appropriate medications being limited or lacking of access to healthcare appropriate medications. Interestingly, there was a significant increase among Pacific children and a decrease among Europeans. With regards to the asthma, Auckland asthma time trends ethnicity data, the focus were as those outlined in this slide here, the questions on asthma ever wheeze in the last 12 months, 12 more attacks of wheeze, etc., sleep disturbance, and so forth. As mentioned earlier, the Auckland asthma my friends, ethnicity data is fairly comprehensive. When we focus on the three major ethnicities, Maori, Pacific, and Europeans, as you can see, there is no significant difference between the prevalence of wheezing wheeze among three ethnicities and selected asthma markers. With Pacific children had the highest prevalence of reported asthma ever diagnosed, followed by Maori and then Europeans. And among 13 and 14-year-olds, there was slight differences between the prevalence of wheezing wheeze between Europeans and Maori. Yeah. I'll try to go into some of the details from here on, but as shown, there is comparable prevalence in asthma ever among European and Maori, with Pacific prevalence lower than both. As you can read from the rest of the slides, so we'll probably go into later on. Other additional results are shown, as shown that frequency disturbance is similar across three ethnicities, with Europeans and Maoris having slightly higher prevalence for speech limitations. It's no new thinking really, and well appreciated that asthma can be well controlled with available treatment, but poor asthma control continues to be common in New Zealand, especially among Pacific people and Maori. Hospital admissions, for example, for asthma in Pacific and Maori are higher compared to Europeans, despite the above figures showing certain symptoms are frequently similar, which raises again the question of appropriate management and access to health services. But in conclusion, I think as stated earlier, suboptimal asthma comes in Maori and Pacific people, involves complex interactions of social, cultural perspectives, health beliefs, practices and communication, and with suboptimal health services delivery, or in fact access to appropriate medications. These barriers and their complex interactions are more well understood and cause for asthma, and I think respiratory health research to be made in New Zealand and Maori Pacific health priority. Thank you for your time, and thank you very much.
So thank you very much for that really wonderful overview of the asthma in New Zealand. Now, our next speaker is Dr. Sabrina Sapford. She's also based here in Auckland, New Zealand. The difference here is she is a rose amongst the thorns. She's going to be speaking to us about eczema. So we're moving a little bit away from asthma. She's going to be talking to us about the ethnic differences in eczema in New Zealand. Dr. Sapford is actually a dermatologist, and she has a special interest in eczema, equity, and improving lung health in underprivileged populations. So it's really, it's a pleasure for me to introduce her to speak to us today on the trends of eczema in New Zealand. Thank you.
Thank you. Thank you so much for that amazing introduction. I'm actually a trainee, but one day I will be a dermatologist. Yes, so I'm Sabrina, and I'm a dermatology research fellow at the moment at Counties Manukau under Dr. Paul Jarrett, who's the head of the department there. And today I'm going to be talking about ethnic differences in eczema, but particularly looking at overcoming our management obstacles. Okay, and just a little bit about me for some context. I'm also a postgraduate student studying atopic eczema in skin of color, collecting clinical data about phenotypes of atopic eczema in Māori and Pacifica patients and New Zealand European patients, as well as looking at quality of life indices and collecting narrative data about how eczema affects patients' lives, and also the barriers that they face. And just thinking through the talk that we just had, There is a lot of, I know I'm the only eczema talk today, but there's a lot of overlap when we consider why patients aren't managed as well as we want them to be between eczema and asthma. I've also been I'm also very grateful to Ines and Philippa and Eamon for involving me in the analysis of the GAN1 data with the help of my department and Paul. So, by way of introduction, eczema is a significant cause of morbidity around the world. The prevalences are up to 22%. And we know that 10% of adults are affected by eczema, and we all know people who have been affected by eczema. And those 10% of adults, some of those patients have had eczema since they were children, but quite a lot of them develop it de novo. And in New Zealand, from the ISAAC studies, we know that the Pacifica and Maori children have higher prevalences than the New Zealand European children for various reasons, which we'll come to. And so why is eczema important? Well, we know that patients with atopic eczema have significantly increased odds of suicide attempts. We know that there's a dose-response relationship between how severe your eczema is and how anxious or depressed you are, or if you have both anxiety and depression. And this is mirrored in the clinical research that I'm currently doing. And eczema is associated with chronic itch and sleep disturbance, which is a part of our scoring systems that we use when we assess patients in clinic. And this can we've all had sleep deprivation. You're not your best. And this leads to school problems, problems with learning. In children, it will lead to problems with accelerating to the level that they should be, and then work problems. So there was a paper about patients who have severe eczema, which is untreated as adults, and they had markedly more time off work, and that will lead to other sequelae. Here we have this beautiful picture from the 2022 Mortimer paper, and I've put a little box around New Zealand there, because the prevalence since ISAAC of eczema is still between 10 and 20%, i.e. it's not great, it's not improved, and we're currently going through the nitty-gritty of that with the help of a professor of statistics, just to really kind of hone down what we can see about what's the context of that. And is there any points of amelioration that we could find, that we can find? And so just by way of example, if we look at the 13 to 14-year-olds, of the patients who actually had active severe eczema, sorry, there's lots of words on this, a very high proportion of them were Pacifica patients, and the next highest, were Maori, and then only 10% were New Zealand Europeans. And that is reflective of what I'm finding in recruitment in my clinical practice. But we're not alone. So if we look at eczema in other indigenous populations, this is becoming, there are more papers coming out about this, because I'm doing the literature reviews towards my master's at the moment. And in Aboriginal populations, severe untreated eczema is one of the most common skin diseases that you see. And when it's not treated properly, then you get all the sequelae. So they get impetiginized, i.e. infected, and then you get sepsis, you get endocarditis, and then what could have been a well-managed, easy condition to sort becomes a major once you go down that road. In First Nations pediatric populations, so Canadian Indigenous populations, again, very high prevalences compared to the rest of the population. And then in Arctic Indigenous populations, so way up in the Arctic, again, very high incidence, 19%. But what are the barriers? So this is what Ines had assigned me. Okay, so what are the barriers? So thinking through this, we know that structural equity issues are important, and I'll come to examining that in a bit more detail. But for us in New Zealand, the number of dermatologists per capita is very low. So we should have 1 in 80,000. We have more like 1 in 300,000. And, I think, we could talk a bit more about that. There are also financial barriers. There are drug funding and prescribing. And I think it's important to acknowledge that interpersonal racism and structural racism, in terms of the way the health service has been structured, is something that we have to address. Doctor training, how we diagnose eczema is very much European skin-centric, i.e. Fitzpatrick skin color 1-2, whereas if you look at our textbooks, if you look at our population, that's not reflective of our population at all. And then I think once you ameliorate all of those, then you can come to patient education. Because actually, how can we expect our patients to understand our, our management plans if all of these other barriers are there? We have to solve all those other things first before we can put it to the patient. We can all do our best as individuals, but that's why I put that down at the bottom, even though it's very important. So in New Zealand, structural equity issues. So we have lack of dermatology clinics in rural areas, and unfortunately we just don't have enough dermatologists. Once you have patients who have had a bad interaction, then there is mistrust of healthcare providers. And just like other countries in the world, socioeconomic position, poverty, residential segregation, all have an effect on atopic eczema clinical presentation. And, the shortfall in medical care of non-European ethnicity children with eczema or asthma or any other significant condition, actually, I've written starts from birth, but then on thinking about it, it actually starts in utero, because it starts when you have disparities in maternal health care, which is also a problem in New Zealand. So comparatively, I found lots of papers about the US, not very many about New Zealand, but in the US, we know that utilization of the healthcare services is different in ethnic minority children, and children who are non-European are 3 times more likely to receive emergent medical care, and those poorly controlled eczema patients were less likely to have seen a dermatologist. This is despite the fact that they have a much higher per capita dermatology, presence, and they are more likely to have persistent disease. And we have to think about that. So even if you've seen a dermatologist, why are you more likely to have persistent disease? Well, there are lots of barriers. So if you look at the barriers, I think there are lots of barriers, which I'm sure lots of people are going to talk about, but inability to get an appointment was the most common barrier to seeing a GP, particularly for Māori patients, which I thought was interesting. And of course, if you face barriers, then you're more likely to be hospitalized due to your condition. And unfortunately, this association was strongest for the Māori patients and not present for New Zealand European families. So, and when we think about the cost of seeing your GP, it's not just this is a child and they have free healthcare, and therefore this should be easy for this patient. Actually, there are lots of costs to seeing your GP. You have to get there, you have to pay for your petrol, you may have to pay for parking, especially here. You might have a cost of time off work, leave without pay, the opportunity cost for all those patients who are self-employed, using up your annual and sick leave, childcare, scripts at the moment is a major point of talking in. My best friend is a pharmacist, and this is our dinner party conversation at the moment. And we must remember that the removal of those charges does not remove all the financial barriers to care. And she was like, please put this slide in. They're better. So this was just published by them. Ooh, I can't see my presenter view. I had a very nice thing that I was going to say here. But as we can see, continuity of care, safety, better adherence occurs when you have fees-free prescriptions. And so hopefully National will not, anyway, yeah. Okay, and so we have this was a paper that discussed sort of a cross-sectional cohort of around the world of patients with eczema. And interestingly, in New Zealand, we have a very high burden of disease and a very low rate of using systemic treatments and phototherapy. And the authors here hypothesized that the reason for this was because of differences in culture or some other reason. Actually, we just probably don't have enough dermatology presence so that all these patients who have severe disease are getting their treatment that they need. Again, an equity issue. And so the other thing I'd like to address is the point of my research, which is barriers to knowledge. So the original eczema criteria for diagnosis involve lots of different things, but there's no specific guidance for darker skin color populations, which I think is an underlying barrier to equity. And if we look at literature reviews, there's not very many papers about this, but we know that it looks different. Oh, thanks. That's okay. I don't need them now. All those slides are gone. That's fine. Okay, probably for the best. You guys didn't need any. So the features noted in the literature include dyspigmentation, and inverse distribution. So rather than being on the flexor surfaces, we're talking about the extensor surfaces, a lichenified appearance. This is important because the patients who are turning up to our clinic often don't have eczema at all. They have some other skin disease. And you know, in my research clinic, I'm giving patients COHA, and we have a place that has free parking, and so I'm trying to ameliorate all those things that we know are barriers. But actually, the referrals from my colleagues in primary care, often those patients don't have eczema at all, and some of that is down to our education at the stages of training, because we don't recognize this necessarily as well as we could. So how do we overcome obstacles and achieve equity? And I guess that's what everybody's here for, right? And what my boss always says, Paul Jarrett, is, you know, a patient comes into clinic and they've got something, and he says, oh, where's the lamp? We need to shine a light on it. And I think it applies to us too. So education, research, and knowledge sharing. We need pro-equity funding levels for dermatologists, for clinical nurse specialists, for more trainees, and more clinicians per capita. Meaningful representation of our Māori and Pacifica colleagues at all levels of the health system, because we have lots of research that shows it helps. And acknowledgement and elimination of institutional racism. And you know, a lot of the papers talk about elimination of institutional racism, but actually we have to acknowledge it, and then we can move forward. So in summary, there are lots of barriers to providing equitable eczema care, and it's important to note that it's experienced differently and presents differently in patients from ethnic minorities. And because our research systems and our scoring systems and our management strategies have traditionally, they're traditionally focused on European skin types, this is to the detriment of others. And this was a line that was from the Growing Up in New Zealand study, which I thought was just, I couldn't have put it better, but future health policy must ensure that health equity becomes a reality for Māori and Pacifica patients. And this starts as individuals for us in our own practice. And those are my Fitzpatrick 3-4 children before they got to the phase of rolling their eyes at me. So it's my go-to end of presentation slide. Okay, thank you.
Thank you very, very much for that really fantastic presentation. So thank you, Sabrina. So we will have our final presentation, which is by Professor Kes Burns. Professor Burns is also a local of Auckland. She's actually a world expert in chronic disease in bronchiectasis in children. She's actually a full professor and a pediatric respiratory specialist here at Starship and Kids First Hospital. And I think it's not by accident that she's been asked today to talk to us about the impact of acute respiratory infections in children in New Zealand. And I welcome Cass to come and give her talk to us. Thank you very much.
Thank you.
Tēnā koutou katoa, ko Ngā Tirokawa ki te tonga te iwi, ko Cass Burns taku ingoa. Thank you very much, Professor Raffaelli. And thank you to the team for asking me to speak today as well. So this is looking at the outcome of severe lower respiratory tract infections in early life. And this first one, not surprising, you'll all know this, that respiratory infections are one of the commonest causes for hospitalisation for children across the world, and also here in New Zealand. And this is just a 2020 report looking at what this is made up of, and you can see 25% are asthma and wheeze, another 25% bronchiolitis, and then 30% other respiratory conditions, which includes pneumonia, and then 16% upper respiratory tract infections. And next to these, I've just put what the numbers that equates to each year. So the top here is looking at childhood pneumonia, which sort of moves between about 350 to 450 per 100,000 per year. and was going up pre-COVID-19 pandemic. And then in the lower part, you can see the hospitalisation rate for bronchiolitis had increased by about 50% over the last 2 decades. And then, as we've seen around the world, the amazing reduction that we got when we had all the sort of non-pharmacological interventions and COVID restrictions with lockdown. A previous systematic review has looked at what happens post-pneumonia and estimated that there is one major sequelae for about 5% of children who require treatment but are not hospitalised, and about 14% if you require treatment, which includes hospitalisation. And unsurprisingly, and certainly unsurprisingly to this audience, what you can see is that the Pacific children are hospitalised 3.1 times more often for pneumonia, Maori 1.7 times more often than non-Pacific Maori. And you also, I just wanted to point out in this that it is definitely impacting our very much younger children. So the first blue bars are the 0 to 4-year-olds, where most of the disease occurs. And again, like many of our other respiratory and other conditions, there is this socioeconomic deprivation association, such that those who are in the poorest quintile are twice as likely to be hospitalised as those that are in the least deprived areas. And I haven't shown bronchiolitis in quite the same way, just showing what's happened over the last 2 decades, but again just showing that it's high in Pacific and Maori more than non-Pacific and Maori. And this is an interesting way of looking at it. Like, what we should at least be able to do is bring everyone down to the people who are currently experiencing the best health. And then that would, if you look across what the purple bars are telling us, it means that we could then reduce by 60% the burden of disease in the lowest, in the most deprived areas of New Zealand, if we could bring it right down to the sort of health outcomes that we're seeing in those who are living in the least deprived. And similarly, you could see that we could reduce the burden of disease by 55% in Maori and 69% in Pacifica if we were able to get it down to European other health outcomes. But the impact is not just the acute disease, it is also what happens next. So these are a number of papers that have looked at following up from early lower respiratory tract infections, what happens subsequently. And you can see that there's been a number that have shown that it's gone on to be associated with preschool wheeze, a number that have been associated with later asthma, a number with protracted bacterial bronchitis, and also bronchiectasis. And this concept is not new, first suggested in 1959. And I just thought I'd pick out RSV, given that this is predominantly an asthma wheeze focus, and just mention that in a number of studies, the odds ratios have been determined at between 3 and 36 for having an early RSV infection and then subsequent preschool wheeze. And then odds ratios of 3 to 17 for subsequent asthma. And also, when you're looking at these papers, the likelihood is that the odds ratio is towards the lower end of that range, and as they are the biggest studies that were compiled for the systematic review. And an increased viral load and disease severity are associated with higher risk of subsequent disease. Infants particularly at risk are these groups as I've listed here, but they're relatively small groups, and by far the main impact is on previously healthy infants. And this is a really interesting study. I'm just going to see, do I have a mouse here? Or like this? Yeah, thank you. So this is a really large study looking at insurance companies in the States, and they matched children who were term babies, no other comorbidities, who were admitted with RSV versus those admitted with non-RSV viruses or no virus detected, and then followed them up. So it was children in the first year, and they followed them up for the next 5 years to see what happened next. And what you can see is this is time to their next episode, and the next episode was either they picked up or claimed some insurance for asthma, so an asthma diagnosis, or they had 3 further episodes of wheeze. And what you can see is this is the RSV, and here's the non-RSV. And it was very consistent across these groups. Again, there's huge numbers in these groups, and the children were matched for age, gender, geography, birth month, and what kind of healthcare plan they had. Now, this, of course, means that they had to have a healthcare plan, and this is likely to have meant that a lot of people in the most deprived socioeconomic state would not be part of it, but it's still interesting finding. So the question is this an association or is it causal? So there could be an association that there are some pre-existing determinants which will mean that the children are more likely to get that early respiratory infection and more likely to get preschool wheeze or asthma or perhaps later bronchiectasis. It could be structural, that they have smaller airways, which means that they're predisposed to that first illness and again to the later chronic conditions, or their environment. So then maybe they've been smoke exposed in utero and then they continue to live in a smoky household, therefore they're going to have an early infection and ongoing chronic disease. There's also a suggestion that timing might be a feature, where if you have your hospital admission at less than 6 months, you're again more likely to have chronic disease later. And then with regard to causal, mice infected with certain viruses continued to have wheeze long after they'd cleared that virus, and the histology looked like asthma pathology. Early viral infection also impairs regulatory T cell function and again increases susceptibility to allergic airway disease. And also in children with RSV, those who went on to get ongoing wheezy episodes had a different microbiome established pre and post that RSV infection than those children who did not go on to get recurrent episodes. And of course there's the possibility of the development of bronchiectasis. So we've been involved in a number of these cohort studies where following up children who've been admitted at less than 2 years of age with a severe lower respiratory tract infection, and in another cohort 400 children who went on, and 1 year and 2 years later 2/3 still had respiratory symptoms even though we were looking at them at a time of supposed health. And a number had gone on to be diagnosed with bronchiectasis. This is another cohort study with our good colleagues in collaboration with Gabby McCullum and Anne Chang and others, looking at children hospitalised with bronchiolitis, and those that had persistent symptoms 3 weeks after discharge tended to be the ones that went on to get bronchiectasis within the next 1 to 2 years. And then in a retrospective review, again with Australia and also with Ros Singleton's group in Alaska, we looked at children who had a diagnosis of bronchiectasis and then looked back to see what their previous medical journey was. And of the 180, there was a mean of 4 lower respiratory tract infections in the first year of life, 2 requiring hospitalisations. And we know that after certain infections, there is a higher chance of developing bronchiectasis. And coincidentally, again looking back, adults with bronchiectasis had 28 to 42%. The centennial event was thought to be a pneumonia in childhood, and 60% reported having a chronic wet cough in childhood. But it doesn't stop there. So early life events can also impact adult lung disease, and it can do this by three mechanisms. The first is a continuation of the disease, so you've been diagnosed as asthma or diagnosed with bronchiectasis, and that's with you for your life. Or prior respiratory disease, even though it improves, may predispose you to having a second respiratory disease later in life. Or, and this is likely to be quite an important component, we get maximum attainment of our lung function in early adulthood around the 20s. And if we don't get that maximal lung function, we start to decline. We either might decline at a faster rate, but we certainly might decline at a not maximal function, and therefore are more likely to get further respiratory events. And in a COPD meta-analysis, all of these were found to have odds ratios of greater than 2 for later development of COPD, and you can see they're all paediatric. This was a really interesting study looking at over 8,500 adults, 35 to 70-year-olds, across both low, middle and high income countries who had lung function. And this just looked at lung function and the possibility of mortality over the next, a median of 8 years that the study ran for. And what you can see is, this is no impairment, mild impairment, which if we saw in clinic, we'd go doing fine. Moderate impairment or severe impairment in the dark blue. And what you can see here is that it didn't matter what happened, it was a marker of all mortality over the next up to 8 years. And then they did split it up into exactly what the mortality was, and you can see that it had different impacts, but it still looked similarly predictive across a number of cardiovascular and respiratory disorders. And the interesting thing is, of course, if you look, the chance of impairment or death was much higher in those who had severe lung disease or severe impairment of their lung function. But the biggest population attributable risk, just because of sheer numbers, was those who were in the mild and moderate FEV1 impairment. And you can see the numbers here are really quite big for risk for death and risk for cardiovascular disease, including higher than almost any of the other parameters except for cardiovascular disease and hypertension. So it's a marker of something. Now, it may not necessarily be respiratory disease, but it may be a marker of your environment or a combination of factors, but it's definitely predictive of mortality. So we want to maintain as best lung function as we can, especially through the growing times, and that growing time is right up until early 20s. So in summary, lower respiratory tract infections in infancy can go on to be associated with chronic lung disease in childhood by association, be it genetic, structural or environmental, or causal, such as a host response, changing immune pattern or altering the microbiome. And of course, it's highly likely to be a combination of these. However, lower respiratory tract infection in childhood can also be associated with chronic lung disease in adulthood by changing the lung function trajectory, predisposing to a second respiratory disease, or just the continuation through the lifespan, and go on to have further diagnoses of asthma, COPD and bronchiectasis in adulthood. So we're all about treating that respiratory disease the minute we see it. Respiratory infection, treat, and follow up. Thank you.
Thank you very much, Cass, for that really fantastic talk. So the message is, let's treat everything. So as a pediatrician, I've learned my lesson now. Write those scripts. Thank you. So I think this brings us to the end of the morning session. We're going to have tea just outside. If we can all please be back at 11 o'clock for the beginning of the next session. Thank you very much.
Using my mic? Okay, so I'll mute all the other ones, otherwise there's some feedback and stuff. Okay. And this is Neil. I'm just doing. No worries. Thank you very much. So, welcome back, everyone. Welcome back, and thank you so much for the incredibly warm welcome that we've had. So we feel well welcomed and very nicely orientated to several really important health issues with a respiratory angle in New Zealand. Now we're going to lift our sights up a little bit and go global. So this next set of talks is all about the Global Asthma Network Phase 1 study. And Neil Pearce here, who's a professor of epidemiology at the London School of Hygiene and Tropical Medicine, is an ideal person to take this next step, having started his journey in New Zealand himself and having been from ISAAC and GAN for many, many years. So Neil, thank you. Over to you for this talk about childhood asthma time trends.
Kia ora koutou, thank you, and g'day. I'll mention this now because otherwise I'll forget at the end. I have to leave straight afterwards to go and see my daughter in Melbourne, so I will finish more or less on time because otherwise I'll miss my plane. So I should say at the beginning what a privilege it's been to work with Ines and Philippa over all these years, and also how important ISAAC and GAN are and how much they're recognised internationally. You know, ISAAC and GAN and Ines and Philippa are national treasures. They're really important. And like most of our national treasures and our politicians and musicians, they get more recognition overseas than they do within New Zealand. So it's good to recognise that here. It applies to a lot of things. Most of our criminals have to go to Australia to get recognition as well, but, you know, but that's another story. Right, I'll do three things. The story so far before we started GAN, and then what has GAN added, and then I'll try and talk about what this all means. So this is the original ISAAC map published in The Lancet in 1998, so it's 25 years old. And I'm going to mainly talk about time trends, but I will say a couple of things about this map because I think it was a game changer. Highest prevalence in the world, 30% of children having symptoms in the last year was the UK. Lowest was Albania and Greece, 3%, so it's 10 times, and it's only about a 3-hour plane flight. And there's huge differences in different parts of the world, which, like Hong Kong and Guangzhou, are very different, even though they're the same ethnic group. New Zealand, before we started this, there's a lot of myths about asthma in New Zealand, and unfortunately you still hear them. First thing you'd always hear in the 90s was New Zealand had the highest asthma prevalence in the world, and it must be something unique about New Zealand. We live by the sea, or we have lots of cats, or we have carpets, and all you had to do was rip up the carpet, kill the cat, and move to Palmerston North, and we'd be okay. And what this showed is that we are very high, but we're equally high to the UK, US, Canada. And what that means is that anything that was unique to New Zealand can't be important. We shouldn't be asking what's unique about New Zealand, we should be asking what does it have in common with these other countries where it's equally high. Second thing you'd hear all the time, but you still see things in the papers now saying we have the highest asthma prevalence in the world as if there's something different here. Second thing you'd hear a lot is my asthma gets better when I go overseas on holiday, so there must be something wrong about New Zealand. When I went to the islands with Sonia, you hear the same in the opposite direction. People saying my asthma gets better when I go to New Zealand. And you hear it all over the world. And the reason is that your immune system has got set up to react to the environment you're in. And if you go into a new environment, it's better for a while. Like I get hay fever. When I moved to London, it was fine for the first year. And then it came back exactly the same as before. So that also didn't mean that there was anything unique to New Zealand. Third thing you'd hear all the time was Maori get more asthma, it must be genetic. And people always assume these things are genetic, and they almost never are. But also what ISAAC showed, more or less, is that Maori kids don't get more asthma. What happens is they get worse asthma care because of institutional racism and problems of cultural safety and so on. And so they don't lose it. most Pākehā kids, if a Pākehā child has asthma at age 13 or 14, which is the peak prevalence, 3/4 of them have lost it by age 20. But Māori kids don't lose it, so it's a failure of the health services. It's not any underlying susceptibility. Anyway, so there's lots more we could say about that map, but I won't. So what we found was that English-speaking countries were the highest in the world. They're all about the same. Latin America's also high, which everyone ignores because doesn't fit our theories, but Brazil is very high. And there's a northwest-southeast gradient within Europe. Tends to be richer countries, but not completely. When we did the GNP analysis, the UK and New Zealand are actually not as rich as we used to be. We were in the second quartile of GNP rather than the first, but we had the highest prevalence. And there's lots of interesting places around the world like West and East Germany and Hong Kong and Guangzhou where there's important differences that we don't really understand. And I could go on for a long time about how asthma is not really an allergic disease, but also what ISAAC showed us, there is some correlation between with asthma and atopia and asthma and rhinitis and eczema, but actually not very strong. So there's big international differences. There are some associations, but most of the recognised risk factors don't actually explain the international patterns, and I'll come back to that in a moment. Okay, so that was phase 1. Phase 3, there were 155 centres who did phase 1, and 105 of them repeated it and did phase 3, and then there was 161 new centres. So obviously to look at time trends, I can only look at the 105 that did both surveys. So this is the, this is what Ines showed you, the centres registered for phase 3. This is the original 1998 Lancet picture, and this is the change between phase 1 and phase 3. And there's a couple of things we see. The first thing is that the countries like New Zealand and Australia are still the highest in the world, but they've dropped a bit. And asthma started increasing after the Second World War, probably around about 1960, and it peaked in the 1990s when we did phase 1. And then it's plateaued and then actually come down. And we still have no idea why it went up, we have no idea why it plateaued, and we have no idea why it's come down a bit. But so countries like New Zealand, Australia are still very high, but comparing phase 1 and phase 3, they've dropped a bit. Some other parts of the world have come up, but not quite as much as we expected, which I'll say a bit more about in a moment. So the overall prevalence hadn't actually changed much. The international differences had reduced to some extent. The English-speaking countries had dropped a bit, and some of the regions where it was previously low had increased. The one thing that was consistently found all around the world was that diagnosed asthma had gone up between phase 1 and phase 3, and I think that was partly a result of ISAAC. If you do the survey and publicise it and increase awareness, kids are going to get diagnosed more. So before you had high prevalence of symptoms, only some of which was diagnosed. Now you have not much change in the prevalence of symptoms, but a lot more of it is being diagnosed as asthma. So what has GAN added? This is the paper that Ines published in a couple of years ago, and this is GAN phase 1. It's getting harder to do these surveys for lots of reasons. It's harder to get money, it's harder to get ethical approval, it's harder to go into schools and so on. So I can't remember how many centres it was somewhere between 50 and 100 centres, but they were mostly new ones. So there were 27 centres in 14 countries who had done the survey previously and did GAN phase 1. So it was only in those centres we could look at the time change. The low and middle income countries we thought would increase, and they'd actually dropped a little bit. They had hardly changed. The high income countries were stable. The only countries that showed some change were the low end of the middle income countries. And I can't remember which ones they were, but it's places like Singapore that have got a lot more Western. Whereas India we thought would increase and actually hasn't. This is for adolescents. This is ISAAC phase 1, ISAAC phase 3 and GAN phase 1. So these are centres that have done at least 2 of the surveys. It's a nice wallpaper pattern or a nice screensaver, but you can't actually, overall there's not much change, which is different from what we expected. And this is children, and once again, some of them have dropped a bit, some of them increased a bit, but there's no consistent pattern. So what does this all mean? Firstly, these established asthma risk factors don't explain the initial map, and they don't explain the time trends. In terms of the time trends, a PhD student of mine in London has done a very detailed analysis. It's not published yet. None of these explain what's been happening over time. But also they don't explain the initial map. And I think the reason for that's very simple, that most of these things don't cause asthma. If you've got asthma, they set off attacks. They're exacerbators, and that's what the patients and the doctors and the nurses notice. But they're not the thing that gave you asthma in the first place. And I'll give you one example, house dust mite, which you hear a lot about here. The highest level ever recorded for house dust mite was sample taken in the living room of someone I work with in Wellington, and we have very high levels. But you go to somewhere like Tucson, Arizona, or Broken Hill in Australia, there's no dust mites, it's so dry. The prevalence of allergy and the prevalence of asthma is exactly the same as in Wellington. So there's something about westernisation that sets up your immune system to become allergic or to develop non-allergic asthma for reasons we don't really understand. But once your immune system's set up, you just react to what's around. And dust mite is dominant, but you get rid of the dust mite, you just react to something else. It's impossible to live an allergen-free life. So these are all things that set off attacks, but they don't explain the underlying prevalence at all. And we've done lots of analyses of these. There's a few things stand out one way or the other, but basically they don't explain the international patterns and they don't explain the time trends. What does? Well, it's something about becoming more Western. Is it greater allergen exposure? No. Another nice example of that is Hong Kong and Guangzhou. Guangzhou is very polluted. The level of allergen exposure, dust mite and cat, is the same in both places. It's the same ethnic group, the same language, more or less the same diet. Prevalence of symptoms in the last 12 months is 15% in Guangzhou and it's 3% in Hong Kong. And they're about as far away as Auckland and Hamilton. So these things don't create the underlying disease. They just set off attacks. And that's particularly true of air pollution. The most polluted parts of the world have low levels of asthma. Not because air pollution protects you, has no effect either way on whether you get asthma. But it will set off attacks if you're primed. So maybe it's a cleaner environment. Most of you will have heard of the hygiene hypothesis, which was more or less invented by David Strachan, who was part of ISAAC and GAN. But there's lots of anomalies, like the high rates in Brazil. The one thing that you consistently find everywhere in the world, in rich countries and poor countries, if you grow up on a farm, you have a lower risk of allergy and a lower risk of getting asthma. And that applies to farms in New Zealand. We've shown it here. It applies to farms in Africa or China or wherever. So there's something about the traditional lifestyle which sets up your immune system in a way which protects you, and we're losing that as we're becoming more and more urban. And actually in ISAAC, we showed that if you grow up in a place with lots of pollens, you have a lower risk of hay fever. And that was heresy at the time, but of course now it's mainstream, that if you want to stop someone getting peanut allergy, you expose them early in life. And the same if you want to stop them becoming allergic to dust mite, it's better to have that exposure early in life rather than delay it to an older age when their immune system won't cope. So we thought we'd discovered something important, and then we discovered this book published in London in 1873, which basically said people are going to get more hay fever as they move to the cities because they're going to lose the protective effect of growing up on a farm. And we still see this consistently today. So conclusions, asthma is going up around the world, but not quite as much as we thought it was. The highest prevalences are in English-speaking countries, but it seems to have levelled off. These so-called established risk factors don't explain the international patterns. The hygiene hypothesis is fashionable and it works better than the old idea that allergens cause asthma, which I think is simply wrong. But The hygiene hypothesis has a lot of anomalies as well. But there is something about rural lifestyle and growing up on farms that does protect you. And perhaps a broader hygiene hypothesis suggests that reduced exposure to factors involved in farming may explain the recent rise in asthma in many Western countries. And if we could identify those factors, then maybe we could work out how to prevent asthma. And the key thing this year's fashion, or last year's fashion, is not so much infections, but just biodiversity. And as we're getting lack of biodiversity, this is affecting our microbiome, and not only in the gut, but in the lung. It's affecting the way our immune systems works. And of course, it's a consequence of climate change as well. So lack of biodiversity is increasingly being related to a lot of diseases, including asthma. So in the meantime, I've studied asthma for about 30 years. I haven't learnt how to prevent a single case. I think I've saved the lives of a lot of cats, so that must have some sort of public health benefit, but we really don't know how to prevent asthma. And anyone who says they do and they know what causes asthma, they're wrong. We know what sets off asthma attacks, but we don't know why people get asthma in the first place. While we're trying to work that out, there's a lot that we can do to improve the management globally, which is quite rightly the focus of the talks today. So thanks for that opportunity, and hopefully I'll be back again sometime soon. No reira hu no I tō tatawhare, tēnā koutou, kia ora mai tātou katoa. Thanks.
Thank you very much indeed, Neil, and safe travels. So now it's my pleasure to welcome Luis Garcia Marcos, who's a professor of pediatrics from the University of Murcia in Spain. He's a member of the steering committee of GAN, has been involved with ISAAC as well, and he's going to take us through the first of two parts of a story. This next part of the story is the burden of asthma in children, adolescents and adults. And Louis' job is to do the children and adolescents bit. When his microphone works. Otherwise, this one also works.
Without it, anyway. I think it's working. Yeah. Yes. Thank you.
Welcome.
Okay. Well, thank you very much, Kevin, for the introduction. And, well, I would like to thank especially Ines, Philippa, and Eamon for organizing this meeting for us. And I must say, following Ines's words about Philippa, that neither ISAAC nor GAN would have been the same without her. And so we are so grateful that she's been with us for so long time. Okay, so just thinking about the burden of asthma, according to the last results of Global Asthma Network, phase 1, and this is mainly the results that we published more or less recently in the European Respiratory Journal. In the case you want to better know what the GAN methods are, you can just check this paper there, which was by Philippa, published in 2017. And in that paper you can see what were the questions that we asked the kids and the adolescents, and also the parents of the children, and which are exactly the same that have been asking in ISAAC phase 1 and 3, and also in GAN phase 1. And it's about wheezing or whistling in the chest ever, yes or no, wheezing or whistling in the chest in the past 12 months, a number of attacks of wheezing during the last 12 months, and also how the wheezing in the chest have affected night sleep, just to grade the severity of the disease. Also, a question on how the attack of wheeze was affecting the speech, also as a way of having an idea about how the attack was or not so severe, and also about the diagnosis of asthma. So the definitions that you would find in the paper I mentioned is about three markers of asthma, current with symptoms of severe asthma, and asthma ever. So the definitions, you got them there. Current with was a positive answer to the question, have you or your child had wheezing or whistling in the chest in the past 12 months? Symptoms of severe asthma involve not only current wheeze, but also 4 or more attacks of wheeze, or 1 night per week sleep disturbance from wheeze, or wheeze after who affected speech in the past 12 months. That was symptoms of severe asthma. And asthma ever was a positive answer to the question, have you or your kid ever had asthma? So you are familiar with those maps that started with ISAAC phase 1, and that's what we found for children in that marker of current wheeze. And again, you can see the legend on the left corner of the map with the stars and the colors, just indicating the amount of asthma, the prevalence of in this case current wheeze, and probably the image that is here and is repeated in every age, in every marker, is how low the prevalence is in India, but we will have the Dr. Nisha Singh to explain us that pattern. Same here, but for the prevalence of asthma ever, and this is for adolescents. We have many more centers, but again, the picture is more or less similar with more or less common prevalence all around the world, with some centers with a little bit higher prevalence, but again, India going in the lowest prevalence rates. Same for asthma ever. There was, as you can see here, quite a difference between centers. You've got the percentiles there, percentile 10 to 90, in terms of prevalence of current wheeze, asthma ever, and severe asthma symptoms for the 2 age groups. And you can see that the ratio between the percentile 19 and 10 is quite high, especially with asthma ever in the 2 age groups, meaning that probably there was a kind of bias for labeling. What is interesting, mainly or probably driven by the Indian centers, is, as you can see in the both lines that have been depicted in yellow, that usually any marker of asthma was lower in low-income countries or low and middle-income countries, both for the adolescents in the upper panel and also for the children or the school children in the lower panels. If you are curious about the ranks or the ranking of the centers, you can take a look here, with India being usually low, Mexico in the middle. Mexico had a lot of centers as well, as you can see. Spain again in the middle, and New Zealand quite high. And this is for current wheeze among children. More or less same image here for asthma ever, again for school children. And things are again quite similar for the adolescents in the marker of current wheeze. You can see India just in the bottom, Mexico in the middle, Spain is somewhere up. I cannot find. New Zealand is quite close to Spain in this case, in adolescents, and more or less same figure here. Okay, what is the difference between children and between sexes in children and adolescents? Well, this is something that's been found previously almost every time, at least in ISAAC, that we just perform this analysis. Usually, during adolescence, being a male is associated to a lower prevalence of any marker, not necessarily to the diagnosis, because kids have been diagnosed previously. And contrary to that, whenever you go to the school children, usually any asthma marker, including the diagnosis, is more frequent among males. Which sounds, it's consistent with all what we know about asthma and within disease. I'm showing you here the correlation between the markers we measure. In this case, in blue you've got the adolescents. Sorry, in blue you got the children, and in salmon or rose or whatever, you've got the adolescents. And you can see that the correlation is quite high, especially for occurring with and severe asthma symptoms in adolescents, and severe asthma symptoms occurring with again for children. So what are the conclusions for this? First, what is I think the most important one is that there is a considerable pattern of asthma among children and adolescents worldwide. Two, that prevalence of any asthma indicators were quite consistently in lower and lower to upper income countries. And there was a correlation between the prevalence of the three indicators, our central level of course, that male gender is associated to higher prevalence of asthma symptoms at school age, while the reverse seems to be the case with adolescents. And to end that the wide differences in prevalence that we found are higher between countries than within countries are probably further explained by environmental risks, such as pollution or protective factors, such as what Neil was mentioning, which are probably more similar in the same country. So I hope I've been able to summarize what the burden of asthma that we have found recently is, and just as Neil said, we'll be very happy to return to New Zealand soon and continue with the Global Asthma Network work in the years to come. Thank you very much.
Thank you very much, Louis. And then to part two of the story, which is the adult part of the story. And I'm delighted to welcome Shenwang Chiang, who's a professor of internal medicine at the university, the Medical University in Taipei, Taiwan. Welcome. And the burden of asthma in adults from GAN Phase 1. Thank you.
Kia ora koutou. Good morning, ladies and gentlemen. It's my honor to be here to share with you the burden of the finding of the GAN Phase 1, the burden of asthma in adults. All right. So perhaps before we go into the detail of the GAN Phase 1, I think there's studies before GAN in adults that perhaps deserve our attention. The European Community Respiratory Health Survey perhaps was one of the most important survey about the burden of asthma in adults. The ECRHS was under the leadership of Peter Burney. You can see that the publication was in 1996. And at that time, the variations of the prevalence of asthma in different populations was not clear why there was low in some country and high in some settings. So the question asked by Peter was that whether the difference was real or was it because of the difference in methodology. So Peter tried to standardize the approach using a questionnaire. So you can see here the detail of the questionnaire that Peter designed. But you see the questionnaire was not ECRHS questionnaire. The questionnaire was termed IUATLD questionnaire because Peter at that time was a member of the Union, International Union Against TB and Lung Disease, and the Union was a platform, now we call it the Union, in the past IJTLD, was a platform for people to participate, especially in the international collaboration. I had an honor to join the Union in 2003 as an international consultant, so I was kind of very happy to to consult Peter about what he has done under the ECRHS using the IJTOD questionnaire. So here are the details of the questionnaire that he used. You can see here quite similar. It's kind of a standardization of the language used to ask. In the last 12 months, have you had wheeze, whistling, and perhaps wheeze with a breathlessness and without call, or you woken up or feeling tightness in your chest by attack of shortness of breath, and then perhaps also when we've been woken by an attack of coughing, and finally, have you had an attack of asthma? So that was the question that Peter and his colleagues in ECRHS asked. So there are 48 different countries from 48 different centers from 22 countries participate in this ECRHS survey. That survey was mainly in Europe, except one country, that is India. So it was a regional population-based multi-center, multi-country study. So you can see here the variations of the different conditions. You can see the different questions and the distribution at the median or 25, 75 centile. And so the conclusion of this survey was that the geographic difference in asthma prevalence exists. It's real, and not because of the methodological difference, substantial, most likely due to environmental factors. So it was quite interesting to read the papers. At that time, the difference in the prevalence between countries has not been properly standardized, and so not sure what is really going on. But then after that, perhaps we get used to that. We know that the prevalence of asthma perhaps really, kind of difference between countries due to also factors mentioned today by previous speakers. The next one is a World Health Survey conducted by World Health Organization. They ask simple questions, current wheezing symptom, and also diagnosed asthma. I will not go into the detail of the question, but just to show you the result of this World Health Survey of asthma in adults. So you can see here, it was more than 300,000 participants from 64 countries, and you see the prevalence of current wheezing symptoms range from 2.4% in Vietnam to 24% in Brazil. And then the prevalence of diagnosed asthma range from 1.8% in Vietnam to 32.8% in Australia. And by gross national income, you can also see the difference. Then comes the GAN phase 1. So you see, it is already shown that there's combination of the colleague from ISAAC and the union. And from the unions, there were many adult pulmonologists, including myself, and Asma Yosoni from Sudan, and then Guy Marks from Australia. So we propose to include adults in the survey, but also the issue of management. So when I designed the questionnaires, I asked permission of Peter, can I use the questionnaire that you use? So it kind of, the questionnaire development was mainly built on the questionnaire used in ISAAC and the ECRHS. And the participants, adult participants, were mainly parents or guardians of the children and adolescents in the GAN phase 1. So I don't go into the detail because that has been already mentioned by Louis about how we evaluate the current wheeze and severe asthma symptoms and asthma ever, because it has been standardized. So it's similar to what has been reported to you about the GAN phase 1 in children and adolescents. So a little bit detail into the statistical analysis. We use the Spearman correlation coefficient to estimate the correlation between age groups using center level data. And we define the correlation to be strong. Every correlation coefficient is more than 0.7, moderate between 0.4 and 0.7, and weak between below 0.4. We also have multi-level log binomial regression to estimate how much the variations was dependent on the central level variation in addition to the within center sampling error. So here are some details about the result. There are 193,000 adults, 54% female, the mean age 38, 16.7% current smoker, 47% of patents, they are patents of the adolescents from the 43 centers, 17 countries conducted between 2015 to 2020. So here are the findings of the survey. You can see that the high-income countries, you see the current wheeze, 10.6% is higher than the upper middle-income country and low-income country, low-middle-income country. Asthma ever, also the high-income countries, is higher than middle-income country and low-income countries. But for severe asthma symptoms among those with current wheeze, you can see they are substantial among upper middle-income countries, 42.4%, but it's also substantial in high-income countries and low and middle-income countries. So severe asthma symptoms, you see the population denominators, the total was about 2.6%. So some details about the difference in countries. You can see the current wheeze range from 3.4% in India to more than 32% in Honduras. For asthma ever, was at 1.2% in Kosovo, up to 29% in Costa Rica. This is the map of the prevalence of asthma ever, and a little bit into the detail. The heterogeneity was high between country and also between centers within country. The center level variation explained 21.8% of the variations in the multi-level analysis, and then women has a higher prevalence of asthma than men. This is the current wheeze, the map of the prevalence of current wheeze. Again, heterogeneity was high between country and also between centers within country. The center level variation explained about 13.1% of the variation. Again, women have a higher prevalence of asthma ever than men. We did the correlation of asthma ever between 3 age groups, so you can see the correlation was quite strong about asthma ever between children and adults, also between adolescent and adult. For the current wheeze, the correlation was moderate between children and adults, was strong between adolescent and adult in this ecological analysis. For severe asthma symptom, the correlation was again strong between children and adults and strong between adolescent and adults. So in summary, the finding of GAN phase 1 was that the overall prevalence of symptoms of current wheeze was 6.6% and asthma ever was 4.4%. The prevalence of severe asthma symptom, 2.6%, but then among those who reported current wheeze was high, 39%, likely due to some issues, perhaps the accessibility and affordability of the proper management of asthma. So healthcare was not really accessible, not affordable. The people with current wheeze is going to suffer from the severe symptom of the asthma. And center prevalence varies substantially both between country and within country, and the burden of the asthma and other conditionality, then go into detail here about hay fever and eczema, was higher in female participants and in higher income country. And finally, there were moderate to strong correlation between the prevalence of asthma symptoms reported in adults and the 2 younger age group in this ecological analysis. With this, I thank you for your attention.
Thank you very much, Shanwan. And now to Dr. Nishtha Singh, who's a pulmonologist from Jaipur in India, who's done GAN phase 1 there. And Nishtha's going to talk to us about the burden of asthma in what's now the world's most populous country, India. Over to you. Thank you.
Good morning, everyone. I'm going to talk about the burden of asthma in the most populous country in the world. This is my center, Asthma Bhavan, which has been the national as well as international coordinating center in various global burden diseases. My country, India, has the distinction of being the most populous country in the world. I will be talking about the burden of asthma, and I will be talking about these salient aspects: the asthma burden, the asthma mortality. The GBD data has shown very high asthma mortality, and I will try to discuss few possible causal factors, and I will be talking about the underdiagnosis, undertreatment, triggers, treatment barriers. With the gloomy scenario of very high asthma mortality, I will share a good news with everyone. I hope you enjoy my talk, but I'm sure my talk will raise more questions than answers. These are the absolute values of global burden, both at the global as well as Indian level. What does this data tell you? Before you all start scratching your head, let me make these slides simpler. This is the fraction of population of India versus the global population. If you look here, the first value shows here 18%. That is 18% of the global population are Indians. And if we look lower down, look at the asthma patients here. It is 11%. That is, the prevalence of asthma compared to the global prevalence is lower. But what happens to DALI here? Disability adjusted life years due to asthma is 27%. That is around 2% of the fraction of global burden. And the most shocking of it is the figure of 43% of asthma deaths. Yes, friends, the deaths due to asthma in India are around 3 times that of the fraction that is happening worldwide. So you might be curious to know why every second global person dying due to asthma is an Indian. Well, underdiagnosis was always suspected, but the magnitude that has been obtained due to our GAN study is mind-boggling. 1 out of all 4 people are getting diagnosed, and what are the rest 3 doing? They are wandering without a diagnosis. GAN study in India was conducted at 9 centers, with Asthma Bhavan being the national coordinating center. The doctor-diagnosed wheezers, what did they found? Amongst the GAN India study, it was found out among the 6 to 7 year age group children, only 18% were getting the diagnosis. Amongst the 13 to 14 year age group, 25% were getting diagnosed. And amongst the adults, 23% were getting diagnosed. That is only 1 out of the 3 or 4 individuals were getting diagnosed. And what were these individuals getting treatment? We can diagnose the asthmatic patients into 2 groups now. One is the diagnosed and second is the undiagnosed. What are they taking as a treatment? When we are talking about the diagnosed wheezers taking ICS, the diagnosed people amongst the 6 to 7 year age group, 30% are taking ICS. 13 to 14 year age group, it is 35%. In adults, it is 26%. That is, only 1 in 3 or 4 individuals is actually taking inhaled corticosteroids, anti-inflammatory agents. Let's talk about the undiagnosed wheezers. The data, the figures are miserably low in this. If we look at the 6 to 7 year age group, less than 2% are taking ICS. If we talk about adults, it is 0.6%. What does it mean? It means that only 6 people out of 1,000 asthmatics are actually taking inhaled corticosteroids. When we talk about the figures in toto, then the ICS use in current wheezers, only less than 2% are taking them regularly, less than 10% are taking as needed, and around 90% are not taking treatment at all. And what about severe asthma? Severe asthma, less than 2.5 are taking regularly. Less than 15 are taking as needed. Even in case of severe asthma, patients are not taking ICS. This is the asthma burden that has been obtained from the GB data as matched with the market ICS consumption. And it was found out that the ICS use actual was less than 10% of what is expected. Time and again, various studies have shown that more the ICS use, less the asthma mortality. These studies have been done in various countries as well as at various centers in India also showing the same. A study that was done around 10 years back showed what are these people actually taking. The undiagnosed groups, those who are not taking inhaled corticosteroids, well, 59% of the asthmatic patients, they take oral medicines. Oral medicines, and when they followed these patients up, they found out that oral medications led to inadequate asthma control. 50% of these patients reported to emergency visit, 32% were hospitalized. And a couple of other studies found that why are people so ignorant? Well, one of the reasons can be that the measurement was not done properly before starting treatment in these patients, and it has been found out that around 9 to 18% of asthmatic subjects, only 9 to 18% use spirometer or peak flow measurement is done before starting treatment in these patients. If we look at the triggers present globally are quite similar to what are present in India. Well, but the Indian asthmatics are exposed to very high levels of air pollution, which I will be talking in my next slide. And talking about the indoor pollutions, the Indian asthmatic woman is exposed to very high levels of biomass fumes, as well as they are also exposed to very high levels of fumes due to frying. Apart from that, there is incense burning for prayer, and mosquito repellent coils, one or the other variety is present in almost every household in India. It has also been seen that ice drinks or curds have been associated to trigger asthma. What is this chart showing here? 60% of the world's most polluted cities are Indian. Yes, my friends, you can see here in the figure, in the table, amongst the first 10, 6 are Indian, and the trend follows down. It has also been found out that the emission of PM 2.5 particles is maximum by the burning of the biomass fumes in the kitchen. As you can see here, this lady working on a chulha. This is an Indian version, a rural of, and so biomass burning is leading to very high emissions of PM 2.5, which is more than the vehicular emission, which is more than the power plants, and which is more than the crop burning. The entire country of India is breathing unsafe air. Pollution has been known to be a notorious trigger of asthma. Also, the annual mean exposure of PM 2.5 in India was 90 microgram per cubic meter. Now, the question comes, what is the safe level? Well, WHO says it is 10. In America it is 12, Europe 25, and India is 40. Does it mean that the European lungs are stronger than American? Or does it mean that Indian lungs are the strongest? Well, it is a matter of debate, but the situation is, and the truth is, that asthmatic airways are inflamed. Yes, my friends, and they are exposed to the dangerous effects of PM 2.5. They are to be protected. There are various varied amounts of treatment barriers that we encounter, and I will be talking to the conditions, the barriers that are specific to India. Well, a study we conducted around 2 decades back, asking the patients, can your asthma be cured forever? Well, you will be surprised to know that only 15% gave the correct answer, that it can be controlled, but it cannot be cured. What happened to the remaining ones? They thought that it can be cured. With the cure notion comes cure expectation. Why are they having this cure expectation? Alternate medicine doctors give cure expectation. There is prevalence of Ayurveda, homeopathy, yoga a lot in India. In fact, on one auspicious day, once in a year, there happens to be this fish festival that happens in Hyderabad, where medicine is put in the mouth of the fish, and that is engulfed by the asthmatic patients. Last year, 75,000 asthmatics attended this, and that gave to the cure expectation. This was the study that was published 20 years back, asking the patients, when do you stop medicine? 91% patients said they stop medicines prematurely. Rest, they stop medicines when they become asymptomatic or when they are able to tolerate symptoms. A more recent study showed that there is 75% non-adherence among the patients of asthma. Asking the patients what is the name of your disease. India is a multilinguistic country, multicultures are there, multiple languages are being spoken. 23% of the patients call asthma by asthma. Remaining, they call it by varied names. Hindi name is saas, khasi, dama. These are the words that are used by the patients. So whenever we are conducting asthma education programs, we always promote patients to speak asthma, to defeat asthma. Amongst the various barriers, this was a very recently published paper which dealt with the asthma as a social stigma. This stigma leads to concealment in the diagnosis, leading to the concealment in the treatment. The parents always tend to find out a more sociable, socially acceptable diagnosis like typhoid. They try to hide that one of their family members is suffering from asthma. Inhalers are strong medicines. This is the notion that people in India carry with long-term side effects. Apart from that, there are barriers like cost of treatment and obviously the notion of cure. But looking at all the gloomy picture of high mortality, high morbidity, do we have a good news? Well, let me share a good news with all of you. This is the GAN India study, and this paper showed some unbelievable data came out, and this was published showing that the Indian prevalence of asthma has decreased around 3.1 in 6 to 7 year age group, 13 to 14, 3, and in adults 3.3%. This is indeed a good news for every one of us. And all three allergic diseases showed a decline: allergic rhinitis, eczema, and asthma. Well, there can be many reasons to explain that. One of them is the replacement of biomass fuels with the LPG gases. And in the future, we are predicting that the emission of PM 2.5 particles will go down, and hopefully it will reduce further. There can be many actions that can be taken at both public level as well as the doctor level. The actions that can promote, that can reduce the high mortality at public level can be like distribution of around LPG gases, around 100 million to the poor, that is under the Ujjwal Yojana. That will definitely reduce the biomass smoke. Then 40% of the poor, they are supposed to be given free insurance, free ICS inhalers, and this program started in the year of 2018. The cost of inhalers are also decreasing in the Jan Aushadhi stores. The air pollution is hopefully going to be reduced by the replacement of biomass cooking with the LPG gases and the use of electric cars in place of petrol. Well, who can reduce the asthma mortality? I believe everyone who's listening to me here standing in India through the online link can do so. Yes, if we adopt all these points in our practice, we will be able to reduce the asthma mortality in our patients. Suspect more to diagnose 75% of hidden asthma. Adopt GINA guidelines as needed, formoterol budesonide in step 1, track 1. The need of a study to evaluate the declining asthma allergy prevalence. Stop asthma is curable notion, because it is not so. Mass level patient education. Speak asthma to defeat asthma and remove stigma. Thank you everyone for your kind attention.
Oh, so we're going to do questions at lunchtime, just and on the online forum. Thank you so much for such a lovely talk, Nishta. So now I'm delighted to welcome Eva Morales, who's a professor of epidemiology and public health from the University of Murcia in Spain. And Eva's going to hopefully pick up on this very important topic that Nishta has highlighted around access to inhaled corticosteroids. So asthma management across the life course. Thank you very much, Eva.
Thank you, Kevin. So it's a pleasure for me to present the results on asthma management across the life course that we get from GAN phase 1. So I have to say that GAN is the only available study in the world providing a global overview of asthma management across life in terms of what are the medicines that asthmatics use, the factors associated with receiving asthma medicines, to what extent asthmatics use management plans, and to what extent asthma is controlled, and what are the factors related to a poor control asthma. So let's see the data. So we have collected data from 63 centers from 25 countries to do this research. So we have analyzed data from almost 500,000 individuals, including data from children, adolescents, and adults. And regarding the information about the main variables, asthma, diagnosed by a doctor, was defined as a positive answer to these two questions. Has this child ever had asthma, and was this child's asthma confirmed by a doctor? So we collected also information on severity of asthma and control, taking into account the information that we got from this question, as you can see. And regarding asthma severity, severe asthma was defined as having at least 4 wheezing attacks in the last year, or having at least 1 night per week of sleep disturbance, or having speech problems due to wheezing. And regarding the data on control of asthma, poor control asthma was defined as unplanned visits to a doctor at least 4 times in the last year, or visiting at least 4 times an emergency department, or being admitted to hospital because of wheezing attacks. So we collected also information on medicine use. We collected information on inhaled medicines. So we had a general question about the use of this kind of medicine. And then we have a specific question about what kind of inhaled medicines. So we have information on short and long-acting beta-2 agonists, SABA and LABA. We have information about the use of inhaled corticosteroids, ICEs, and also a combination of ICS and LABA. Regarding information on oral medicine, we did the same approach. We have a global question, a general question, and then we had specific questions for specific oral medicine. So we have information on oral SABA, oral corticosteroids, leukotriene receptor antagonist, and theophylline. And finally, we classified countries according to gross national income data obtained from the World Bank, and the 4 categories were collapsed in 3. lower income countries plus lower middle income countries, upper middle income countries, and high income countries. So here you have the results. These are the prevalence, the use of medicines by asthmatics. You have the results, the prevalence of using inhaled medicines and oral medicines. And as you can see globally, inhaled medicines were more frequently used than oral medicines. And among them, the most frequent medicine used was inhaled SABA, followed by ICS. So here you can see the results on asthma severity. So 32% of children, 26% of adolescents, and 31% of adults had severe asthma. And if you take a look at the country income, you can see that the lower income of the country, the higher proportion, higher prevalence of severe asthma for the 3 age groups. Here we have the information of the use of asthma medication according to asthma severity for the 2 kinds of medicines, and in general the higher severe symptoms, the higher use of inhaled medicines and oral medicines. Here you have the data on asthma control. So 44% of children, 55% of adolescents, and 61% of adults had good control of asthma. And if we take a look at poor control of asthma, you can see that for the 3 age groups, the lower income of the countries, the higher prevalence of poor control asthma. And here we have the data on the proportion of individuals with severe asthma not taking ICEs alone or in combination. And overall, for all the countries, you can see that 44% of children with severe asthma don't take ICEs. And if you take a look at the data according to the income of the country, the lower income of the country, the higher proportion of patients with severe asthma not taking ICEs. For example, for children, you can see that the proportion of children in low-income countries not having ICEs goes up to more than 60%. So, and now the results of having an asthma management plan. We have the data overall, and we can read this data in another way. It means that almost 40% of children with asthma don't have a management plan. And if we take a look at those patients with severe symptoms, almost 30% of children with severe asthma don't have a management plan. And to conclude with the results, here you have the results on the factors associated with receiving asthma medicine. So I want to highlight 3 points. First one is that the higher severity of symptoms, the higher probability of taking inhaled SABA medicine. On the contrary, the lower income of the countries, the lower probability of having inhaled SABA or ICEs. And if you have a management plan, it's more probable that you will take inhaled medicines like SABA or any inhaled medicine. And here the results on factors associated with poor control asthma. And as you can see, the higher of severe asthma, the higher probability of having a poor control asthma. And maybe the most important result is that the lower income of the country, the higher probability of having a poor control asthma in the 3 age groups. And in that case, this is an association, and this is a cross-sectional study, but reverse causation is not an option to explain this. So here are the final remarks. Oral SABA and theophylline are used widespread against current recommendation. Asthma severity and poor control are more frequent in patients living in lower income countries. The use of asthma management plans are not widespread in individuals with severe asthma. A high proportion of asthmatics reporting severe symptoms are not taking ICEs alone or in combination with LABA. Independently of treatment received, low income of the country is associated with worse control of asthma. The proportion of severe asthmatics not on ICEs is higher in lower income countries. And independently of asthma severity, patients in lower income countries receive less SABA and less ICEs. So, improving compliance to recommended asthma medicine use and assuring the availability and affordability of essential medicines across the life course are urgent needs if we want to mitigate asthma burden, particularly in less affluent settings. And, well, data are numbers, no? Numbers are just numbers. So I want to make a final remark that behind numbers there are people and lives. So thank you very much for your attention.
Thank you very much indeed, Eva. That concludes this morning session, where we've heard data from the GAN phase 1. We've got a big problem here. There's a major burden of disease. About 1 in 10 children, or about 1 in 15 adults around the world have got asthma. We've heard from India about a shocking number of deaths that are occurring. We've heard about such terribly poor availability and use of inhaled medicines for people with asthma, even people with severe asthma. And amidst all of this, a very, very limited use of inhaled corticosteroid-containing inhalers. So we need to solve this one. And this afternoon is all about how we are going to solve this with others. So I know there are some burning questions, and there's every opportunity to discuss those burning ones at lunchtime. We're deliberately keeping all the talks very short and focused, recording them all to be available in the on-demand and this discussion environment that we'll present to you a bit later on, which will mean there'll be maximal opportunity for interaction, discussion, and asking and answering of questions for those who are on the live stream and on demand. So thank you everyone for all of your attention. Thank you for everyone who has spoken. And now there is lunch. Please come back at about 1:15 or a little bit before, and we'll get going on solving this one between us. Thank you very much.
lunch. But because we knew you would be feeling a little postprandial, we put some of the best speakers in the next session just to wake you up. So the first speaker today is actually a recorded talk by Dr. Sarah Raylands. Sarah is actually currently the medical officer for chronic respiratory diseases based at the WHO NCD department. Sarah is actually a pediatrician by training, and she's really done quite a lot of work on asthma in LMICs, particularly in Malawi. So thank you very much to Sarah for giving us this talk. We look forward to hearing it. It's a pre-recording. Thank you so much.
Thank you for the opportunity to talk about WHO priorities to improve global access to asthma care. I'm sorry that I'm not able to join you in person. My name is Sarah Raylands. I'm the medical officer responsible for chronic respiratory diseases, working with the non-communicable diseases department at the WHO headquarters in Geneva. During my brief presentation, I'm going to focus on the mandate for WHO's work relating to asthma care and key priorities under 3 strategic areas: supporting impact at country level, technical products, and global leadership. WHO's work is driven by the priorities of member states, so let me start by introducing the commitments and targets that member states have agreed to. In the past decade, there have been 3 United Nations General Assembly high-level meetings on non-communicable diseases, or NCDs. The outcome of the first, in 2011, was the UN Political Declaration on NCDs. Following on from this, the WHO Global Action Plan for the Prevention and Control of NCDs was endorsed by the World Health Assembly in 2013. The Global Action Plan contains 9 voluntary targets, including a 25% relative reduction in premature mortality from cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases by 2025. Specifically relating to medicines, there is a target of 80% availability of the affordable basic technologies and essential medicines required to treat major NCDs in both public and private facilities. The timeframe for this Global Action Plan has now been extended until 2030 to align with the Sustainable Development Goals. I'm sure you're aware the 2030 Agenda for Sustainable Development was adopted by the United Nations in 2015, following on from the Millennium Development Goals. Sustainable Development Goal 3 includes targets to reduce mortality due to NCDs by 1/3 and achieve universal health coverage, including access to safe, effective, quality and affordable essential medicines for all. These high-level political commitments relating to universal health coverage are reflected in the current WHO programme of work, which extends until 2025. This work plan includes 3 interconnected strategic priorities: achieving universal health coverage, addressing health emergencies, and promoting healthier populations. The work of the NCD department relating to access to asthma care falls under 1 billion more people benefiting from universal health coverage. Under this target, there's also a specific outcome on improving access to essential medicines for primary health care. So WHO has a clear mandate to improve access to asthma care as part of universal health coverage and within the wider global non-communicable diseases agenda. Many of you will know that in 2022, Dr. Tedros was reappointed to serve a second 5-year term as our Director General. At this time, Dr. Tedros set out 5 strategic priorities for WHO. I'd like to draw your attention to the second point, to reorient health systems towards primary health care. Why is this important for chronic respiratory diseases? Well, over 500 million people need diagnosis, treatment and long-term monitoring for chronic respiratory diseases. The vast majority of asthma deaths occur in lower middle-income countries, where health systems are under-resourced and overstretched. It is essential that chronic respiratory diseases are embedded into primary health care, so that people can access treatment closer to home, reducing costs and improving the likelihood of successful long-term outcomes. So the WHO work plan and Dr. Tedros' priorities speak strongly to the importance of universal health coverage and primary care. How can we make sure that asthma care is part of this and that we support access to effective diagnosis and treatment, particularly in lower middle income countries. Our priority is to support countries to deliver integrated care for asthma and chronic obstructive pulmonary disease, or COPD, taking opportunities to address prevention, diagnosis and management of these conditions with a holistic patient-centred approach. WHO has many tools to assist member states to do this. The foundation for integrating non-communicable diseases into primary care is PEN, the WHO package of essential non-communicable disease interventions. PEN includes protocols for the acute and long-term management of asthma and COPD and lists essential diagnostic tools and medicines. The interventions included in PEN are among the most cost-effective options included in the recently updated Appendix 3 of the Global Action Plan. We've recently developed indicators to monitor the delivery of chronic respiratory disease diagnosis and management in primary care. We also have guidance on integrating comorbidities with tuberculosis, and we have new guidance on therapeutic patient education, including case studies and examples on asthma. We also have training and tools to assist health workers advise patients on tobacco cessation and on reducing exposure to air pollution. And we're in the process of developing guidelines for the management of asthma in children and adolescents, together with the Department for Maternal, Child and Adolescent Health. However, the implementation of these recommended interventions is challenging in many lower middle income countries. There is a long way to go to reach the Global Action Plan target of 80% availability of the affordable basic technologies and essential medicines to diagnose and treat asthma. This chart shows data on the availability of basic diagnostic technologies from the 2021 WHO Non-Communicable Diseases Country Capacity Survey. You can see here peak flow measurement is shown in dark purple and spirometry in lighter purple. The vertical axis shows the percentage of countries where basic diagnostic technologies are available. And here by available we mean that the technology can be accessed in more than half of public primary care facilities in the country. So if we focus on low-income countries and lower middle-income countries, we can see that peak flow meters are available in about a quarter of low and low middle-income countries. And spirometry is even less available. In fact, it's only available in about a third of countries overall. This is data from the same survey on the availability of basic medicines for chronic respiratory diseases. Each cluster of 3 columns shows bronchodilators in turquoise blue on the left, steroid inhalers in dark blue in the middle, and combination inhalers in light blue on the right. Again, focusing on low-income countries and low-middle-income countries, potentially life-saving bronchodilator inhalers are available in approximately 60% of countries. In other words, they're not available to 40%. And for steroid inhalers, these percentages are reversed, and the inhalers are not available in approximately 60% of low and low middle income countries. So in almost 2/3 of low and low middle income countries, inhaled corticosteroids, the basic cornerstone of asthma management, are not available. So the data we have show that in countries where premature asthma deaths are the greatest problem, there are huge gaps in the availability of key medicines and technologies. This also represents a huge opportunity to make an impact. However, we need strong global leadership to advocate for improved access to diagnostic tools and treatments. The Global Alliance Against Chronic Respiratory Diseases, or GARD, is a network convened by WHO since 2006. We're working hard to revitalise this alliance and align the work of GARD member organisations with the priorities of WHO. GARD members include many prominent global and regional respiratory organisations representing respiratory specialists, academics, nurses, primary care and patient groups. We've also developed a GARD community on the WHO Knowledge Action portal on NCDs. This online platform supports networking and information sharing among GARD member organisations and the wider respiratory community. Additionally, we're working with stakeholders to raise awareness of chronic respiratory diseases through internal and external events and publications. The 4th United Nations General Assembly High-Level Meeting on Non-Communicable Diseases in 2025 represents an opportunity to raise awareness of chronic respiratory disease and to highlight progress, challenges, and most importantly, potential solutions. When considering solutions, it's absolutely critical to engage people who have first-hand experience of living with asthma to understand the challenges and develop interventions that are locally relevant and implementable. WHO has some experience of working with people with lived experiences of diabetes and cancer over the recent months, and this is an area which we're hoping to expand for chronic respiratory diseases in the coming year. So to summarise, what are the opportunities to accelerate progress? We have the technical tools to support the integration of chronic respiratory disease prevention, diagnosis and management into primary care. Interventions for prevention and management of chronic respiratory diseases are cost effective and are included in updated Appendix 3. We need to see them included in national essential benefit packages alongside those for other prevalent non-communicable diseases. Access to diagnostic testing and inhaled medicines remain a challenge in many countries. Peak flow meters and bronchodilator and steroid inhalers are classed as essential resources in PEN. They are the most basic elements of chronic respiratory disease care that must be available in primary health care as part of universal health coverage. We need to support robust monitoring and evaluation as another vital component of primary health care. The implementation roadmap for the Non-Communicable Diseases Global Action Plan highlights the importance of national data to drive action and strengthen accountability. And we need to build and strengthen partnerships to advocate for improved access to asthma care and co-create solutions. The Global Asthma Network is an example of how greater impact can be achieved by working together. I'd like to thank you all for your attention, and I wish you all the best for an engaging and productive meeting.
Accessing medicines globally. So for the next 2 sessions, we have Dr. Marie Stolbrink. As you see, she's actually the one person in this whole program who gets to speak 3 times. So she is going to speak to us about a lot of work that she's done around availability, affordability of inhaled medicines for people mostly in low middle income countries, because of course we know what the burden of the disease is, but most importantly, can people access this treatment? So the first talk will be on her review of the availability of medicines, and then she'll lead on to the next one on a survey that she conducted in a number of low middle income countries. Welcome, Marie, and I look forward to hearing from you.
Thank you very much. Yes, 3 talks are slightly daunting, especially after being part of such an eminent program. So thank you so much to the organisers for inviting me. So my name is Marie Stolbrink. I am a Wellcome Trust Clinical PhD Fellow and also an adult respiratory physician trainee based in the Liverpool School of Tropical Medicine and Stellenbosch University in South Africa. And the bits that I'll be presenting today were all part of my PhD, where Professor Mortimer was one of my lovely supervisors. And none of this work would have been possible without all the collaborators who've been very instrumental in all of this worldwide. So the first presentation is around our review of the availability and affordability of inhaled medicines in low and middle income countries. So we've heard this before multiple times today already, but as we know, low and middle income countries are disproportionately affected in terms of asthma morbidity and mortality. And as Dr. Rylands just explained, the WHO Global Action Plan as well as the Sustainable Development Goals state that globally everyone should have access to essential medicines for non-communicable diseases. The WHO regularly updates and creates the essential medicines list, which addresses the priority healthcare needs of the population and suggests medicines that are safe, efficacious, and cost-effective. And these are the medicines that should be available to everyone globally. The first UN General Assembly high-level meeting on NCDs happened in 2011, and this was also the year when there was a shift from oral medicines towards inhaled medicines on the essential medicines list. So our first question was, what has happened since then, seeing that we have this deadline of 2030 where everyone globally should have access to medicines? So we performed a systematic review following pretty standard systematic review methodology, and we looked at published studies that were conducted between actually 2010 and 2022. Apologies about this. And we searched 7 databases looking for terms covering chronic respiratory diseases, essential medicine, availability, affordability, cost, and low and middle income countries. And we used established methodology to define what's available and what's affordable. So for available, we looked at whether medicines were present in at least 80% of the studied outlets as per the Global Action Plan, and medicine was considered to be affordable if 1 month's treatment costs less than 1 day's wage of the lowest paid government worker. And this again is by WHO and Health Action International established methodology. So we found over 4,000 unique titles, looked at over 300 full text, and eventually included 29 studies. These covered 60 low and middle income countries, and 5 of the studies looked at multiple low and middle income countries. Africa was the most represented region with 25 countries, and generally the studies were of good quality. Delving into a little bit more detail now. So you'll be seeing lots of maps in my presentation. So here we look at bronchodilator availability. Gray means it's a low and middle income country, but we don't have any information about it. Pink means the availability is less than 80%, and blue means the availability is more than 80%. So for SABA inhalers, 23 countries reported on availability, and in only 6 of them, SABA were available as per this definition. If you look at affordability, so different colors, yellow means it's unaffordable in this country, and green means affordable. 51 countries reported on affordability, and SABA were affordable in 20 out of these 51. At the bottom there, you can see the median price ratio. So this is essentially looking at how expensive is the medicine in the country compared to the international price ratio. The numbers themselves are not that important, but essentially if it's less than 1, it means it's cheap, and if it's more than 1, it means it's expensive. But the important thing to note is that there was a wide range in cost or price for the same medicine. And generally, SABAs were relatively cheap, requiring 1 to 4 days' work for 1 month's treatment. So then moving on to steroid inhalers, and again looking at availability. 22 countries reported on availability, and it was only available, as per our definition, in 1 of these countries, which was Suriname. Looking at affordability, 36 countries reported on it, and it was affordable in 10 countries. Again, you can see there was a wide range in prices, and they were slightly more expensive than SABA inhalers, requiring 2 to 7 days of work for 1 month's treatment. ICS-LABA were introduced onto the essential medicines list in 2017, so there is an element of bias here, obviously. But only 3 countries reported on availability, and it wasn't available in any of them. And again, affordability, 5 countries reported on it, wasn't affordable in any of them. And again, there was a range in prices as to how expensive the inhalers were. If you look at the Gambia, it almost took 1 month of paid work to pay for 1 inhaler. So we found there was a lot of heterogeneity between the studies. So some studies looked at public, some looked at private outlets, some looked at generics, some looked at branded inhalers, some looked at primary care, some looked at secondary care. And these were also countries that had varying disease prevalences. This is why we prepared a narrative review. You will have noticed we didn't do any meta-analysis. What you will remember from the maps is that there was mostly grey, so not much, we don't know what's going on. But from the data that we did have retrospectively, we could find out that inhaled medicines were largely unavailable and unaffordable. And sort of daily treatments, long-term preventative treatments, were less available and more expensive than SABA inhalers. And there were big cost differences between countries. So from that, we concluded that we needed up-to-date data, and luckily, someone went on and did that work. Firstly, just to say thank you to everyone online and here for listening. You can find the full text article there, and please get in touch. Okay. Right. Okay, moving on. So this is looking, so in the previous session, we've just discussed, looking retrospectively, we need up-to-date data on inhaled medicine availability and affordability in low and middle income countries. So we went on and did that work, and again, it was done in collaboration with lots of people. I'm very grateful to them, and I should have said at the start as well, the review was done in collaboration with the WHO, so very grateful to them. So we've just spoken about this. I feel like I'm repeating myself, but we know that low and middle income countries have the highest burden of asthma. We have this target of 2020 of getting inhaled medicines or effective medicines to everyone globally. There is a World Health Assembly happening in 2025, so we need up-to-date data. There was an excellent survey conducted in 2011 that looked at 52 low and middle income countries. And this survey looked at SABA inhalers and also ICS. But more recent guidelines, so GINA, ICS LABA are now first-line treatment, and that wasn't included in the previous survey. And the recent systematic review that I've just presented in the previous session, and if you're looking at this online, look at the previous session, showed that medicines were often unaffordable if they were available, and there was large heterogeneity between the studies. So, conducted a cross-sectional survey among healthcare professionals working in low and middle income countries. They used a standardized data collection form to collect data on availability and cost of essential medicines as defined by the WHO model list of essential medicines. The data collection form was designed using established methodology, and we looked at standardized formulations. Our collaborators collected data from 3 facilities. So from a pharmacy, from a healthcare facility, such as a clinic or a hospital, and also finally the Central Medicine Store or the National Procurement Center, which is usually a governmental organization that procures medicines at wholesale prices and then distributes them within the country. So the collaborators collected data on cost, and this was in local currency that was then converted into US dollars. And again, we used this cutoff for affordability of 1 month's treatment costing less than 1 day's wage of the lowest paid government worker. And we got this information from the International Labour Organization. So the survey was conducted between June 2022 and May 2023. And we managed to collaborate with 60 low and middle income countries, making this the biggest study of this type so far. In the table, you can see the median cost for 1 month's treatment across the different facilities and the different classes of drug. So there are a couple of things to notice. So one is short-acting beta agonists remained the cheapest drug class. And if you look at the ICS LABA in particular, at the cost, it's quite a lot. And then there was a markup in prices between the Central Medicine Store and then the facilities where patients themselves would actually purchase medicines in terms of price. Again, if you look in terms of days of work, which is this DOW, you can see that ICS LABA required around 3.5 or 4 days of work to pay for 1 month's treatment, which is quite a lot. And I've just given you there for comparison how much it costs to buy a course of oral steroids. So even though we know inhaled medicines work, the oral medicines remain much cheaper. Okay, next set of maps in slightly different colors. So here we look at inhaled SABA availability and affordability in the pharmacy or the healthcare facility. So if a patient in that particular country chose to go to a pharmacy or, say, a hospital, would they be able to, A, find the drug, and B, would they be able to afford it? Blue means yes to both. Yellow means they would be available but not affordable by our definition. And orange means they were unavailable. So we found that overall SABA were available in 58 out of the 60 countries. But they were available and affordable, so blue, in 37 out of the 60 countries. So almost, almost 2/3 overall they were available and affordable. If you compare this to ICS, you immediately see that there's less blue, a bit more yellow, and more orange. So ICS overall were available in 42 out of the 60 countries, and they were available and affordable, so blue, in 24 out of those 60 countries. So they were available in about 2/3 of the countries that we studied, and then they were affordable in just over half of those countries. And then if you look at ICS formoterol, we've chosen the 200+6 microgram per dose there, but the story for the 100+6 is very similar. So this was again available in actually 40 of the countries, which was possibly more than we were expecting, but it was affordable only in 9 out of those 60 countries. And I think what's very striking about the ICS formoterol is the range in price between the countries. So if you look at the median costs there and the ranges for a pharmacy or a healthcare facility, it goes up to almost $80 a month from zero. So zero means it's subsidized, it's free for the patient when they attend the facility. Right, so SABA, almost universally available, and then affordable in a fair proportion of the countries. ICS and ICS-LABA were actually available in a similar proportion, that they were both available in about 2/3 of the studied countries, but ICS-LABA were much less affordable. There was a large variation in cost between the countries, and also there was a difference in cost between the central medicine store and then the outlets where patients would actually go and obtain the medicines. Given all this, economic realities may reinforce inadequate treatment with SABA and oral steroids alone, so treating exacerbations or symptoms on their own rather than actually preventing disease. And this may ultimately result in avoidable morbidity and mortality. So where do we go from here? So one way is thinking about responsible price setting. So governments and industry and everyone else thinking about, what's the daily wage in this particular setting, and can we benchmark our prices off ideally ICS-LABA against this? The other way is to think about price setting in terms of comparing, so setting the same price for an ICS-LABA, which we know is more effective and works better, against a SABA. We need to address it at multiple points in the procurement chain to improve access, and we need buy-in from multiple stakeholders. And we also need specific cost-effectiveness data for low and middle income countries. As we know that not only is the morbidity and mortality, but also the cost for asthma driven by exacerbations, and preventative treatments are expensive. So thank you everyone for listening, and all the collaborators. Couldn't have done it without you. The paper's available in preprint. Keep an eye out for the final publication.
Thank you very much to Marie for really giving us this really valuable work. And I think it's very important now that we know what the numbers are and we have an idea what needs to be done. So I'm going to introduce the next speaker, who's going to be talking together with Marie. So you can see that the PhD supervisor is making the poor candidate do a lot of work, Kevin. So Shami Jayasureya is a clinician GP who's also an NIHR clinical lecturer at the University of Sheffield. Shami has done quite a lot of work in terms of asthma, and I think if you have seen the clinical standards for asthma in low middle income countries, she was one of the lead authors. So she's very passionate about asthma, I know, and I look forward to hearing your combined talk on how we can improve access to inhalers and international stakeholder meeting. Thanks.
Hello again. Not too much from me now. So Dr. Jayasureya and I will be discussing the international stakeholder meeting that was conducted in collaboration with the International Union Against Tuberculosis and Lung Disease. And the theme of the meeting was improving access to affordable, quality-assured inhaled medicines in low and middle-income countries. And for this, a variety of stakeholders were invited to take part. These were involved in procurement, treatment, and policy making with regards to access to inhaled medicines. They were approached from July 2021 onwards, and some of the contributors submitted audio recorded presentations on the topic in advance. And these presentations, as well as 2 publications, were circulated among all stakeholders that attended the meeting before the meeting, and then focused group discussions were conducted during the meeting. The meeting was moderated using a topic guide, which was developed in line with strategic objectives of the Union and the WHO, and it was around 3 themes, which were barriers to access, solutions, and finally pathways to solutions. We had a visual storyteller during the meeting who essentially captured key messages live and created outputs so we could engage the participants and guide the discussions around this live. The transcript of the meeting, the chat, because it was a virtual meeting, and the images that were prepared, which these are part of, were analysed using a thematic framework approach, which is a qualitative approach to analyse key patterns in meaning and broad themes from qualitative data. So the meeting was conducted in February 2022, and 20 presentations were available before the meeting. 58 key stakeholders attended, and these included patients, healthcare practitioners, members of national and international organization, industry, and also the World Health Organization.
Hi, can you hear me okay? So I'm just taking over from Marie, but still this analysis and work was predominantly led by Marie, so I'm just giving her voice a rest today, really. So I'm going to briefly discuss the thematic analysis findings from this stakeholder meeting. And essentially, there were some barriers identified with themes around low awareness of chronic respiratory diseases. So this seemed to centre around the sort of lack of availability of medications and equipment, which have been touched on throughout the talks today, and also around a lack of guidance. And limited data on chronic respiratory diseases was felt very much to drive its low priority in terms of looking at the supply chain and having it addressed within countries. And procurement, again, was fed into by the low awareness and the limited data, with everything coming together really to really have a sort of poor advocacy level for chronic respiratory diseases in countries. So it wasn't all negative. The discussion did switch to thinking about some solutions for that are listed there. But as Marie alluded to, during the discussion there was a live scribe who created a lot of these visuals that we're seeing today called Nifty Fox. And they generated this roadmap, really, which highlights the facilitators of the discussion that was had. So just highlighting those. Awareness was discussed, but specifically with a focus on co-creating that with patients and advocates. Also clinical guidelines, but with very much a focus on LMICs, and then using that to think about the supply chain and the challenges that holds. The other areas that were discussed were around data collection, but also this idea of wider sharing of data across country and sharing lessons learned in different settings, across settings, to try and communicate messages across different policymakers. And this is all sort of targeted to facilitating, to moving towards trying to get a World Health Assembly resolution for improving inhaler access and quality assured access to medicines for chronic respiratory diseases. So this is the overall visual image from that stakeholder event, and it's been published in the International Journal of Tuberculosis and Lung Disease. And this also additionally shows the key players who were represented at that meeting, which Marie's already alluded to earlier in the discussion. Thank you, that's all I was going to say.
Thank you very much to Marie and Shami. So we're going to move on to our next talk. The next talk is by Professor Asthma El-Soni, and she is actually one of the GAN Steering Committee group members. And Asthma unfortunately couldn't be with us today, but she has a talk which is recorded for us, and it's on improving access to affordable inhaled medicines and international collaboration. I think Asthma is usually the one who gives very wise words, so I know that in this talk, because she's actually a public health specialist, she's going to give us some thoughts of how we can access inhalers and how to collaborate internationally. Thanks.
It's an honor for me to be part of this timely and important Global Asthma Network Symposium. NCDs, among them respiratory diseases, are one of the largest global health burden of the century, which makes international collaboration translated into sustainable financing, pursuing science, research and development fundamental. All recent 3 high-level meetings on health in September 23 and the World Health Summit October 23, where one of the panelists was the director of the WHO NCD department, asked for action. And just last month, the COP28 organized the first ever Climate Health Ministerial Day, indicating that global leaders must recognize climate change as a health crisis, and that supporting health represents a foundational investment in human capital and economic growth, which means that the role of respiratory organizations, among others, need to be intensified to prove the core benefits in putting people's lives and livelihood at the heart of climate action. During these few minutes, we'll take you through the accomplishment by the WHO, GAN and other organizations, a comprehensive lung health project, roles and responsibilities of international community and other key stakeholders, a framework for improving access to inhaled medicine and funding targets, the way ahead. Indeed, substantial work has been achieved by important organizations working in lung health throughout the years. There were 3 high-level meetings of UNGA on NCDs. The first was in 2011, where GAN was a strong player. The fourth planned in 2025, which has projected premature deaths from NCDs to be more than 100 million, compared to 15 million in 2018. The Global Asthma Network Phase 1 study estimated that about 1 in 10 children had wheeze in the preceding year, of whom almost half had severe symptoms. The Global Initiative for Asthma in the 2019 strategy, there was a historic change in recommendations related to asthma management. Again, the WHO published extensively. The Global NCD Action Plan was updated until 2030. Development of the NCD implementation roadmap achieved by the 6 WHO regions, which is a great achievement. 2023, the WHO produced an important report on selection and prioritization of NCD primary care facility-based indicators, CRDs included. The Union held a broad-range stakeholders meeting around access to inhaled asthma medicine in 2021. Despite of these appreciable efforts, asthma remains underdiagnosed, inadequately managed, and insufficiently funded. At this meeting, there was consensus regarding the importance of generation of data to inform policy, practice, and serve as an advocacy engine. Production of data through building the capacity of public health programs, including improved procurement mechanism, to become data-rich, information-rich, and action-rich, is key to asthma management. The prospect of a world where no asthma patient is left behind is a realistic objective that can be achieved through international collaboration with the right commitment of leadership, targeted resources, but will only be realized as and when quality of care is prioritized as the key area of focus. For the 2030 NCD roadmap to materialize and countries to achieve reduction in asthma burden, true, it does require progress towards universal health coverage. Nevertheless, investment in disease-specific asthma programs is indispensable. The Union model is an innovative approach for delivering decentralized, effective, efficient care at primary and district level. The Union model is a comprehensive lung health project with two aims: provide affordable access to quality assured essential asthma medicine for low and middle income countries through asthma drug facility, promote a quality improvement package for the diagnosis, treatment, and management of asthma. The story goes like this. The Union, drawing from years of seeing how things has worked in TB, used the same 5 original components of directly observed treatment strategy. After all, it's a public health strategy, user-friendly model, which has improved asthma management, that strengthened and standardized services, that has worked for TB and HIV and produced impact, being used for bidirectional screening for TB and diabetes. It exists globally, where low settings and elsewhere attend years of experience. It's a comprehensive package that was funded by the World Bank, where the Union designed ADF and provided countries with procurement and quality assurance of services, as well as technical support related to selecting, quantifying, managing, and using essential asthma medicines. These services were accompanied by the Union technical guidance about how to establish asthma programs in the general health services and generate data for quality improvement and policy advocacy. Countries start with the national adaptation of the guide, situation analysis, pre-intervention, training, intervention of standard case management. You basically launch the program, scale up, expand, replicate in other countries, and create demand for medicine. A one-time pilot isn't super great and not a good idea for the community you want to serve and doesn't have a good business prospect. We need to get to the millions out there needing the services and continuity of the business. Governments, drug companies, and development partners need certainty around demand into the future. Generation of data by countries is a key component. Therefore, monitoring and evaluation tools are needed to provide countries and global actors with data on management outcomes. The packages are a guideline, 9 training modules, an instructor and participant manuals, Epidata software used for entering and analyzing the data. It is simple, user-friendly, and can easily be used by paramedics. All patients have asthma treatment card, while a register book was kept to produce quarterly reports on treatment results, treatment outcomes. You make your investment case by generation of data and proving impact. There is no contradiction between the WHO model practical approach to lung health, known as PAL, and the Union comprehensive approach to lung health. PAL functions at primary level, general information on CRDs, morbidity in outpatient register collected at national level. Comprehensive approach to lung health functions at secondary level, uses treatment cards and register to collect specific information on asthma patients and management outcome. It's a missed opportunity not to look at the level of synergies between the two strategies. True, there is a WHO list of best buys and other recommended interventions to address asthma and respiratory diseases. Yet it is left to countries to pick and choose. No standard configuration of actors for decisions and policy related to CRTs. It's high time to move from best buys to action. Generation of globally comparative data is imperative across countries. These are some of the publications by participating countries. The International Multidisciplinary Program to Addressing Lung Health and TB in Africa, IMPALA, led by LSTM, recently managed to replicate the union model in Tanzania, adding a community component. Other than strengthening the health services and improving asthma management, there were financial benefits, reflected in reduction of emergency visits and frequency of hospitalization. And this is not unique to Benin, China, and Sudan. Previous pilots showed similar results, Algeria, Vietnam, among other countries. Its ADF arm kept prices down by running a limited competitive process through pool procurement. To grow such a mechanism into a sustainable practice, it takes local and global awareness around it. We are all aware that the sustainability of evidence-based intervention takes time, hard work, and patience, dealing with the bureaucracy and complexity at ministries of health. To become routine practice at sufficient intensity for sustained achievement of desirable program goals and population outcomes, it took countries and the WHO nearly 2 decades or more to move with the Union TB DOTS model globally. It was initiated in 1977, adopted by the WHO in 1993, and rolled out in 2002. This slide summarizes what I have just managed to say. Making medicine available and accessible, though important, very important, but it is not enough. What countries require is universal access to asthma diagnosis, treatment, and care. Universal access to asthma diagnosis, treatment, and care, which necessitates international collaboration to all packages, research and innovation, establishment of international procurement distribution mechanism, launching a multi-country experience of standard case management followed by scale-up and demand creation, in order to promote an aligned response across health systems for long-term sustainability. The world is looking for the creation of a solid strategic partnership, accountable across the board, from head of states to the local asthma clinic, aligning interests of academic, non-academic partners, and mandates of development partners, pharmaceutical industry, public and private sectors, the affected communities and civil societies, in a framework where the WHO sets the stage thoughtfully by defining expectations and responsibilities, and giving autonomy and trusting the world-leading lung health organizations in a competitive collaboration to deliver and prove their complementarity and added value to the roadmap in areas specific to asthma and CRD. And therefore, I think the way ahead, advocate for a World Health Assembly resolution to urge member states to raise the priority of CRDs and international action. Action is needed, with a global commitment to sustainable financing, science, research, and innovation. Strengthen procurement and supply management at regional and national level, the overall procurement system. Or revive or create an ADF-like model. Conduct a costing analysis to find out the funding requirement to implement standard case management or similar approaches. Conduct a health policy analysis to identify the constraints related to scaling up. Examine the synergies and opportunities to redefine lung health priorities in primary and secondary care setting. Call for the WHO to continue to provide global leadership for asthma response and to shift from trustworthy best buys and promote a CRD package of standardized case management with regular international monitoring. This is very important. Generate globally comparable data to prompt countries to work harder towards WHO 80% availability target of NCD's essential medicine and the overarching aim of universal health coverage. Create a strategic partnership to strengthen synergies, accelerating multi-sectorial action and accountability. To ensure integrated, equitable, people-centered quality package at the governance, systems, and service delivery. We acknowledge the patients, the communities, the health personnel at country level, the GAN, and the union consultants. The principles of this model are generic and are relevant for a broad array of public health services in resource-limited settings and beyond, including NCDs. However, the principles are a basic minimum requirement, and any compromises of them could undermine their results. And thank you.
Thank you. Thank you to Asthma for that presentation. So our next speaker is Dr. Karen Bissell. I think she may be well known to some of you. She is a local, so she's from the University of Auckland. She's a senior lecturer at the School of Population Health. And I think the one thing about Karen is she's been a member of the GAN steering committee, but also has done a lot of work with the union around the asthma drug facility, which you've heard a lot about. This is the lady who's done a lot of the work behind the scenes on that. And I think we're quite interested to hear your thoughts. Karen, she's going to be talking to us about the Global Asthma Report, which I think we have now seen a number of times. And she's going to also talk to us about advocacy around access to inhaled medicines. Thank you, Karen.
Kia ora koutou. Ko Karen Bissell tōku ingoa. So my name is Karen, and I am a local and a global, and anywhere we can talk about improving access to medicines. So the presentation that I have is going to follow on very closely from my union member colleague Asthma Elsoni's presentation, but I'm going to home in on one particular project, the asthma drug facility, and draw out some of the learnings, some of the challenges we met, and present those for consideration as we think about revitalising efforts to improve access to medicines. Obviously, advocacy can be defined in a lot of ways. At the union, we have always had a strong social justice component to any advocacy work that we're doing in public health. So it's about reducing and eliminating inequities, making sure that everyone has access to health and well-being and can enjoy healthy lives. We obviously have within advocacy the component of lobbying, so we have to do that get that political commitment. So as I refer to advocacy, it's going to be really quite broad, and obviously the Global Asthma Report from the Global Asthma Network is one tool of bringing together all of the data that we've heard about today, all of the epidemiological data as well as management lessons. It brings together academic studies and reports from health services as well as patient voices. So we'll be trying to learn lots of lessons for our conclusions today. Now, at the union, we were very influenced by all the work that was going on and has always been going on in TB. So we have always worked closely with the WHO. We saw how the global strategy for TB was branded and into the DOT strategy, and how some of the advocacy gurus at the WHO managed to packaged together the components that had actually come from fieldwork by colleagues at the Union and countries that were members of the Union. And they took these components, put them together and branded this package and set targets. During the course of the Stop TB movement, they also looked at the gaps, detailed the gaps. That's the type of work that the Global Asthma Network and ISAAC, obviously as the founder of this movement, had started doing. So looking what are the gaps and putting those out there so that the funders and governments and member states can see those gaps. And then in TB it was rolled out, the STOT strategy was rolled out with resources to countries and with expectations, so targets, expectations and transparency, and key to existing TB programs. So I'm thinking that as you look at this, you're going to be comparing it with what we have in asthma, and there are some key differences probably that you can see with what countries have available as they try to improve access to essential asthma medicines. So I'm going to just recap for you the points that Asthma put up on a slide, which is the points of the Union model, developed initially for TB, and we set about adapting these for asthma. And that is the 5 guiding principles in this package. So for a number of years we had been hearing from members of the Union and all of the other international organisations, members of GINA, members who were saying, we want to work on asthma, but we don't have the medicines. We can't do anything without the medicines. And so we looked around, we asked questions, is there another organisation going to be doing some procurement? Is there anyone? Silence. So Dr. Nils Bilo, whose photo you saw this morning, pragmatically decided that the Union would see what it could do about procuring medicines. So we set about thinking that we could kind of copy and adapt the Global TB Drug Facility, which was running at the Stop TB Partnership, hosted by the WHO. We knew there'd be differences. We thought we could probably adapt and get some success by following the model. So I will highlight some of the challenges and some of the hope that we generated with our Asthma Drug Facility project. So as you saw in Asthma's presentation, we had 2 aims for the Asthma Drug Facility. And one was to get the access, so to provide access. We were going to help countries procure medicines, get hold of these medicines. They were going to make sure they were quality assured, and they were going to be the essential asthma medicines, not the expensive innovator ones. And we were going to do this so that it was adapted for low and middle income countries. Because we don't want to just provide medicines, we know that it's not just medicines that are going to help our people with asthma manage their asthma. We had this requirement that anybody who was going to be procuring through the ADF needed to sort of sign up to working on all components of asthma activities. So this is this quality improvement package based on the 5 components: diagnosis, treatment, management, and making sure that they would be collecting data and checking, monitoring and evaluating their performance. That obviously reduced the number of countries and services that could be involved, because not everybody was prepared to be looking at data and collecting data and working in that way. So we started developing it in 2005, and we were operational from 2009. Big lead time. We worked out that it was a very complex product to be working with. Inhalers, very complex. So I think that's a caution to us when we're talking about improving access to essential medicines is we need to have pharmacists really involved and right from the beginning, because it's a complex product. It's ingredients that are delivered, it's a dynamic process, and in fact we can't talk about generic inhalers, we can only talk about generic manufacturers, because it's a whole process that delivers the ingredients in a puff to a patient. So because we had to start from scratch, we had to organise the qualification of these inhalers and the qualification of the sites. And this was a very complex process initially for us. And this is partly because they are not in any type of pre-qualification program. So for all the TB medicines, there's a WHO pre-qualification program that does all that work so that the quality assurance is, the chain is already there by the time you're ordering the medicines. So that was a huge amount of work. It's a caution. Procurement strategies that was our colleagues who were pharmacists, procurement specialists, and able to advise. We kept the prices down. We used limited competitive processes. We had pooled procurement. We had clients paid in advance for the medicines. We aimed to be self-sustaining financially. That was our aim, but we didn't achieve that. So in fact, that's why you can see 2009 to 2013, the asthma drug facility was sadly closed down in 2013 because we were not self-sustaining, and a few other contextual reasons. But we did achieve a lot of learnings, and a lot of the work that Asthma has just described to you is based on the learnings that were enabled by having the ADF and the union comprehensive approach to lung health in place. So some of the data that we got out of our activities, and I say our, that means it includes the pilot countries that worked with the ADF. Just in a few years of operation, we managed to reduce the prices by around 50%. So the light blue colour is before ADF, and then in the first round of purchasing and the pricing from the manufacturers, managed to reduce those prices, and then 2012 the prices went down again. If we'd kept going, believe this would have gone even better. When we're talking about costs and data that can be used to convince, to advocate for improving access to medicines and advocate for asthma management in countries, this was a very simple calculation that we did with countries, and it was to prove the point that if you don't have your essential medicines in place and you have people going in for unnecessary hospitalisation and emergency visits, you're actually paying, the health service is paying a huge amount of money that it doesn't need to be paying. So if you look at the first row there, the cost of hospitalising a patient for 2 days, 4 times a year, for example, and you can see in our pilot countries what that would be. They gave us the data. Cost of 1 year of affordable essential asthma medicines for a patient with severe asthma, that was the cost, the real cost at the time of the medicines. And then a very simple calculation, what does that save in hospitalisation costs? A huge saving. This doesn't even talk about any of the incidental costs, the interruption to people's lives and their families' lives. This is another advocacy tool, trying to get the message through. We're throwing money out the window if we are treating asthma by having people come to hospital all the time and blocking the beds that could be used for other people who are in the emergency department room. So what were some of the achievements that we managed with the asthma drug facility regards procurement and prices? Asthma Ilsoni has talked about some of the data and the health service policy achievements, but here are some specific to the ADF's procurement and sort of pricing work. So, contrary to popular belief, we proved that inhalers from generic manufacturers that had not actually yet been registered in strictly regulated countries were up to quality standards of the WHO. So there had been doubt that these generic manufacturers would be able to be compliant with the standards, but in fact we proved that they were. We interested the pharmaceutical companies. They stayed with us for 3 consecutive expressions of interests. Despite the fact we had very small orders, they were all interested in this market. Again, contrary to popular belief that they weren't interested in asthma in low and middle income countries, they actually were. The prices kept coming down. Our prices started being used as international reference prices by Management Sciences for Health and others. GSK, an innovator company, became a supplier, so they were obviously interested as well in this market. So we had an effect, even with a relatively small undertaking. We did influence the market, which was very pleasing. And then after that, we did have an effect. We saw a tiered pricing system in most of the African countries. The prices were higher than what ADFs were, but still they were lower than before for innovator products. So ADF was an example that we can advocate with to show what you can do with very few human and financial resources and minimal bureaucracy for countries. There are some howevers, but I'll get to those. Here's a recap of the countries that managed to order. We had a few that had to cancel because the funding suddenly had some restrictions. When we were closed down in 2013, we were actually diversifying the interest, and it's quite possible that we would have had some bigger clients, some UN clients, some more TB programs and ministries that might have come on board had we been able to continue a little bit and had we had funding. I just highlight that the ADF was a platform for advocacy. It allowed us to take the message specifically about access to medicines, so a very good platform to advocate for access, obviously alongside a lot of much bigger players, but we played our role, and that was a niche that we could play to just hammer home the message about essential medicines and the targets that were being set for those. Academic publications, and then Global Asthma Report. We've had these two ways of publishing. Very important to get messages out there in different ways to advocate. Different funders and decision makers are sensitive to different types of messages. So I'm really heartened to see all the things that were in Sarah's presentation, all the WHO documents, and I think that's great if across the board collaboratively we can have so many publications coming out. One very interesting piece of research that was done, recently published, so this last year, which looked at 4 mechanisms for pooled procurement. One was the ADF, one was the Global TB Drug Facility, and compared and contrasted and worked out what were some of the disadvantages and advantages of the different contexts and ways of working. So this is the conclusion that they reached for us, and this is important for advocacy because it reminds us exactly what we're supposed to be doing. The ADF did not reach a sufficient market size to manage a sustainable pooled procurement mechanism because asthma was not perceived as an urgent problem that needed to be solved by potential buyer countries, resulting in a lack of demand. In addition, potential buyer countries lacked the financial capacity to procure asthma medicines through ADF, while the ADF failed to attract sufficient donor funding due to the nature of the disease. Another quote, putting a problem successfully on the national and or global agenda is highly political and directly linked with the ability to mobilise funding. The ADF struggled to create local political awareness and convince potential buyers to allocate sustainable national budget to asthma treatment. So a lot needs to come together in this advocacy, and in countries there's advocacy at all levels that needs to be activated. I'll just finish very quickly with a couple of slides with some suggestions or considerations. I repeat the message, making medicines available is not enough. Creating country demand for the essential medicines and the care is essential. We need to get more data, standardised data, cost effectiveness, emergency admissions and hospitalisations avoided, more surveys about essential medicines, coordinated advocacy, multiple spheres, not just our sphere, but broader NCDs, universal health coverage, get into the World Health Assembly, find champions at all levels. And we need to spark engagement between all of those who can make a difference: health personnel, professional societies, civil society, patient organisations, health services and the workforce trainers. Our pharmacist colleagues believe we need to support national and regional procurement mechanisms to improve their procurement of asthma and other chronic respiratory disease medicines. We would like to advocate for WHO to receive adequate funding to assist countries to strengthen their procurement systems and practices. It does need to be in the countries that the capacities are strengthened, and this is different departments at WHO that need to work together on this, but this is crucial. The package for chronic respiratory disease from the WHO, and it would be wonderful. It would remove barriers if asthma inhalers could be pre-qualified. A final slide with some acknowledgements for the work on the asthma drug facility and at the Union. And for Nishta, I just point out this little slide is from El Salvador, and they're saying asthma es controlable. It's not curable, but it's controlable. It is controllable. We can do it. We need everybody. Okay, thank you very much.
Thank you very, very much for that, Karen. Some wise words. So hopefully we will be able to take some lessons learned from the ADF and get a way to procure medicines for asthmatics. We have a slight tweak to the program because we've done so well. We've been racing ahead. So we're going to have one of the talks from the next session by Dr. Sai Buladudwa. She's a PhD candidate here at the University of Auckland. And she has done some work she's doing work on how to improve access for healthcare in children with ARIs, acute respiratory tract infections, to improve morbidity and prevent mortality in Fiji. But today she's going to be talking to us about a paper on patient's perspective, which was co-written with her. And I really look forward to Sai's talk. If we can get it loaded, please.
I send you greetings from Fiji and also send apologies for not being able to be there in person. I'm presenting this on behalf of the patients whose stories and perspectives we share, and my co-authors who wrote this paper jointly with the patients. That's the citation of the paper that we wrote, which has been recently published by the New England Journal of Medicine Evidence Patient Platform. This is the outline of my talk this afternoon. Asthma, as we all know, is a highly prevalent non-communicable disease. Most people with asthma can be treated effectively with inhaled medicines on the World Health Organization Essential Medicines list, but accessing affordable care near their homes is a challenge for many people with asthma living in resource-constrained low and middle-income countries, or LMICs. In this talk, we share stories from 6 men, women, and children living with asthma from different LMICs across the 6 WHO regions. The stories are their own perspectives, each written, as I'd mentioned earlier, jointly with a local co-author identified through the Global Asthma Network. We start with the WHO African region, specifically in South Africa. This is Noxolo. I'm 12 years old and I live in Escowini, a township 21 kilometers away from the Queen Nandi Regional Hospital. The trip to the hospital from our home takes 45 minutes by taxi. I was diagnosed at this hospital with asthma when I was a few months old. The doctors provided good treatment for me with budesonide and salbutamol inhalers until I was 5. After that, my asthma could not be controlled with those medicines. I was referred to a bigger hospital in Durban, 171 kilometers from our home. The doctors there changed my medication to a combination inhaler and an asthma pill, Montelocast. My asthma has improved slightly, but I'm still unwell. For example, I've missed 10 to 12 days of school almost every month in the last few months because I get breathless and wheeze. I also cannot play sports at school or play for long with other children, and this makes me sad. It is a long distance to the hospital in Durban, and I have to leave my home with my mother a day before my appointment. We normally leave after school at 4:30 p.m. to the regional hospital, where we spend the night at the outpatient department so that we can take patient transport at 4 a.m. to arrive in Durban at 8:30 a.m. Although this is difficult, I'm getting help and better medicines at the hospital in Durban. The second patient is from Mexico. This is Adriana, sharing her son Pedro's story. My son Pedro was born in December of 2018. We live in southeast Mexico, 4 kilometers away from the nearest medical clinic. Our house has mold growing in the walls because of the humidity, and Pedro is in close contact with a dog and poultry. When Pedro was 2 years old, he began to suffer recurrent cough, together with breathing difficulties and wheezing about once a month. These episodes were so bad that Pedro was admitted to the local hospital. He was diagnosed with pharyngitis and bronchitis and managed with antibiotics, mucolytics, and oral salbutamol. I was very anxious that he wasn't getting better, so last year we consulted with a specialist in a nearby city who diagnosed him with uncontrolled asthma and persistent allergic rhinitis. He's now treated with a combination inhaler of fluticasone and salmeterol and has been well for the last year. From India, we have Usha sharing his story. I am in my 40s and I've had asthma since I was 15. I first became aware of shortness of breath and chest congestion while I was playing kabaddi, an Indian sport. I consulted several doctors and was diagnosed with asthma. When I was younger, my parents claimed that typhoid was the cause of my breathing difficulties since it was a more socially acceptable illness at that time. To ensure that no one saw me using my inhaler, I was told to use it only when I was alone in a private space. I didn't tell my spouse or my in-laws that I had asthma until I had an asthma episode in front of them a few years after my marriage. Even so, I still only use my asthma treatment inhalers when my symptoms are very severe. I first try to put up with the pain of the symptoms before taking medicine, but finally use them when the symptoms become intolerable. The inhalers I need are available for free from government hospitals, but I use them less because I think inhalers are strong medicines that could cause long-term side effects. As a middle-class family, we experience financial strain when we purchase expensive asthma medications. I've also seen Ayurvedic and homeopathic doctors to reduce my spending and reliance on inhalers. But even after treatment with their medicines, I still need to use my inhalers. I wonder if there's any cure for asthma. Next we have Aydin from Turkey. I am 52 years old and I've had asthma for 13 years. I have been treated and my disease controlled with inhaled medications for the last 2 years. I live in Hatay, Turkey, where there was a big earthquake in September 2023, leaving most of the houses, including mine, uninhabitable. I had an asthma exacerbation triggered by the dust from debris due to the earthquake and the cold weather. I had a telephone consultation with a doctor, during which I received advice about the use of my inhalers, breathing exercises, and controlling the feeling of panic. However, since the healthcare system and pharmacies were not working, I could not get the medications. I was able to get a 4-day supply of methylprednisolone from another patient, and I took it. Finally, after 8 days, I was able to see a doctor in person who was visiting the earthquake area, and they were able to give me the inhalers that I needed. I wanted to use a nebulizer, as I had in the past, but the lack of electricity made this impossible. I refused to evacuate from the area as my family was helping with the search and rescue efforts. Now we go to Sudan, where we meet Motaz. I am 50 years old and I have 5 children. We live in a village called Mustafa Qureshi. Every member of my close family has asthma. My father had severe asthma, which led to his death in 2017. He carried a reliever inhaler in his pocket at all times, and when he traveled, he took a vial of aminophylline with him for when he had an asthma attack, not responding to inhalers. We've always been aware of the importance of nebulizers in our home. We have multiple nebulizers in our village and salbutamol solution from Saudi Arabia. Our home serves as an emergency room for many people with asthma. Medicines for asthma were poorly available before the war. For example, we often struggled to find salbutamol. Since the war, obtaining asthma medicines has become extremely difficult and very expensive, especially in remote areas. Friends outside Sudan extend a helping hand by sending us medicine. Traditional medicines can help with other diseases, but there is no local or herbal alternative for asthma. Last, we come to our Western Pacific region, to Fiji, where we meet Tomasi. I am 62 years old and I live in a rural village in Tailevu. I was told I had asthma only 10 years ago. I remember that first episode being triggered by the cold after having gone out fishing at sea. I remember wheezing and having trouble breathing. I was taken to the nearest health center where I was given oxygen, injections, and some other medication and told I had asthma. I was also given a blue inhaler, but I've never used it. I'm scared to use it because my brother had one of those inhalers and he died of an asthma attack. Things that set off my asthma are mostly the cold and physical exertions such as farming. This has impacted my life quite a bit, as subsistence fishing and farming are our way of life in the village. I feel the effects of change in climate as we have colder weather now during our cooler months. I've had more frequent asthma attacks because of this. Last year I needed to go to the health center almost every month. I have a truck ready at home and I drive myself to the health center with one of my daughters to accompany me when I get an attack. I was recommended a herbal medicine by a church minister about 5 months ago. It's the root of a particular tree. I drank it only once and have not had any asthma attacks since. I can now go back to the sea in the cold to fish and do farm work, and I don't have any problems. I never thought my asthma could be cured, and I would like others to know about this herbal medicine as I think it works. These patient stories highlight several of the kinds of difficulties people with asthma in LMICs face, trying to access effective, affordable, and timely asthma care and the impact of asthma on their lives. Although each story gives only a single patient voice from these countries across the 6 WHO regions and are therefore far from exhaustive, they all offer examples of common scenarios faced by people with asthma and their families. These 6 stories illustrate the impact of severe asthma on their lives and common barriers to healthcare access. Children with asthma are particularly vulnerable to missing out on school and outside of school activities due to poorly controlled asthma and the time-consuming and costly efforts to obtain healthcare, especially for patients living in rural areas. Healthcare facilities are commonly not well set up to offer diagnostic tests such as spirometry. Asthma medicines are similarly poorly available and commonly unaffordable, with the exception of certain oral medications like salbutamol, theophylline, and prednisone that are associated with a high risk of adverse effects. There are signs that inhaled salbutamol is becoming more available and affordable, which is preferable to the oral alternative, but without matched availability and affordability of inhaled glucocorticoids as recommended by the Global Initiative for Asthma, or GINA, this will likely encourage harmful salbutamol monotherapy. Disaster scenarios, for example earthquakes, war, climate change, further exacerbate access to healthcare. These scenarios cause physical loss of infrastructure, loss of expertise, for example, the loss and displacement of doctors, nurses, pharmacists, the disruption of supply chains, information systems, governance, and leadership. Stigma and misguided beliefs about asthma treatments add further complexity to achieving effective asthma control. Asthma often carries an unwarranted social stigma, particularly in the context of arranged marriages. At the same time, some have beliefs that asthma is curable and adopt unconventional complementary treatments in preference to inhalers, for example, salbutamol, that provide only transient relief and may be seen as habit-forming. With appropriate effort and investment, we could overcome or at least mitigate many of the issues that make life with asthma in LMICs a struggle for so many. Key to achieving this is to overcome the problem of limited availability and affordability of essential WHO medicines for the treatment of asthma. The backbone of GINA Track 1 recommendations, for example, inhaled glucocorticoid formoterol, is on the WHO essential medicines list, yet is largely unavailable and unaffordable in LMICs. Were this to be overcome, the global burden of asthma, morbidity and mortality could be substantially reduced. There are some important opportunities ahead to help catalyze the much-needed change, including the current Global Asthma Network Symposium, the UN High-Level Meeting on Non-Communicable Diseases 2025, and the Sustainable Development Goals 2030 deadline, which is approaching. With so much to be gained, we cannot afford to sit on our hands any longer. Thank you very much for your attention.
Thank you very much. This brings us to the conclusion of this session. We will be starting again with the next session, again on access to inhaled medicines. But I think it's actually a good place to stop by hearing what our patients think and how they perceive their disease, which I think is very important. So we'll be breaking up for tea. We will be back at 3:15. And we'll be starting with Professor Helen Riddell from GINA. Thank you very much. Meet in 30 minutes.
Great, well thank you, and welcome back to the last part of the day. So it gives me great pleasure to introduce Helen Riddell. Helen's a Professor of Respiratory Medicine. She's at the Wilcock Institute of Medical Research in Australia, and her role for the purposes of this talk is as Chair of the GINA Science Committee. So Helen's going to tell us about GINA and the case for change in guidelines for LMICs. Thank you very much.
Thanks very much, Kevin, and thanks for the opportunity to be here. It's just lovely to put faces to the names of people that I've known and respected your work for such a long time, so thank you. So there's my statement of interest, and probably the one that's most relevant to this is that I was one of 4 people from GINA who actually lobbied for about 5 years to eventually have the studies done in mild asthma that have resulted in a change in our guidelines. So I want to start with what is a focus of our attention, and that is I've described as the global catastrophe of preventable asthma deaths. You can see on the right there that 96% of asthma deaths and 84% of DALYs are in low and middle income countries. Let's think about it in terms of the goals of treatment from the perspective of the clinician and the patient. So for many years, the goals of asthma treatment were expressed in terms of asthma control, which was limited to symptom control. So few asthma symptoms and quickly relieved, no sleep disturbance and no exercise limitation. So things like the asthma control test and the asthma control questionnaire assessed that, and that was considered to be enough. However, what we've emphasised in GINA since 2014 is the importance of risk reduction as that second component of asthma control. Maintaining normal lung function, well, that's the one about which we have the least evidence, but preventing exacerbations, preventing asthma deaths, and minimising medication side effects. And I've specifically put oral corticosteroids in there because we're now aware from evidence from the UK of how quickly and with how few courses of oral corticosteroids you start to see an increased risk of permanent adverse effects such as diabetes, cataract, osteoporosis, fragility fractures, heart failure, myocardial infarction, pneumonia. So there's a very high priority for many reasons to reduce exacerbations. Now remember though that the patient's goals may be different. They may be completely different from this, so I always say you should ask the patient what their goals are. And importantly, symptom control and risk may be discordant. In particular, patients who have few asthma symptoms can still have severe, life-threatening or fatal exacerbations. And that fact at the bottom there is what has changed asthma management very substantially. So we saw the outcome from the multi-stakeholder meeting and this lovely design that was developed during it. So I'm focusing here on the clinical guidance, but also on awareness and communication with patients, because that's an essential part of how we can change outcomes. This is the current WHO guideline for treating asthma. So it starts with inhaled salbutamol and then adds low-dose inhaled corticosteroids and then higher dose inhaled corticosteroids with the option that if they're available, you would use a combination ICS-LABA there. Step 4 adds theophylline, and then step 5 adding prednisone. And in fact, this is remarkably similar to the very earliest asthma guidelines. So these were from 1992, similar 1989, the first published asthma guidelines from Australia. So you can see it starts with short-acting bronchodilator alone, then inhaled corticosteroid, then a higher dose and adding theophylline, oral beta-agonist or long-acting inhaled beta-agonist there, and oral corticosteroids coming in then. These are remarkably similar, yet we've had a huge change in evidence since then. So first, why not treat with short-acting beta-agonist alone? Because this is the fundamental problem that we're trying to change in GINA. And as I mentioned, people with apparently mild asthma, so few symptoms, can have severe or fatal exacerbations. And in this study from Sweden, I think it was, Norway, up to 27% of asthma deaths were in patients who had very occasional symptoms, so once every couple of weeks. A second reason is that exacerbation triggers are unpredictable. So viruses, allergen, pollution, stress, all of these things you can't necessarily plan for when you will change treatment to adapt to that. And then, as I mentioned, even 4 or 5 lifetime courses of oral corticosteroids increase the risk of these adverse effects. Short-acting beta-agonist treatment alone is the main focus of the problem. For those who are on a short-acting beta-agonist-based regimen, there are some additional effects if short-acting beta-agonist is used regularly. So even 1 to 2 weeks, taking it 2 to 4 times a day, so this is very little compared with what a lot of people are doing, increases airway hyperresponsiveness, reduces bronchodilator effect, so the patient feels less benefit, increased allergic response, and increased eosinophils. And most of this evidence came from lovely work done here in New Zealand. So what you can see is that you can get a vicious cycle very quickly. If someone's discharged from hospital with a regimen of regular short-acting beta-agonists, they can very quickly get into the scenario where they're not getting as much benefit, so they take a bit more. And overuse of short-acting beta-agonist, which is seen in many countries, but not in every patient, is associated with an increased risk of exacerbations and increased mortality. But the key problem with starting short-acting beta-agonists is that, I would say boldly, it is doomed to fail, because what you're doing is training the patient to regard this as their best and primary asthma treatment. So in this qualitative study, for example, in young adults who were overusing short-acting beta-agonists, the blue one's good because you can just have a couple of squirts and get back to what you were doing. So if you give the patient as their first treatment something that works lightning fast, why would they come back to you, even if they're using it every day? It doesn't make sense to the patient. And so, in addition, when the next thing you have to offer them is something that they have to take regularly every single day that has the nasty word steroid in it, and that where you might say to them, if you're prescribing inhaled steroids alone, well, you won't immediately feel a benefit. You'll get a gradually increasing benefit. This does not compute in the patient's mind. Now, as we know, low-dose inhaled corticosteroids are exceedingly effective in asthma. And this is why they're so core to asthma guidelines. They reduce hospitalisation by about 1/3 and reduce asthma deaths by about 50%. Now, in mild asthma, low-dose inhaled corticosteroids almost halve the risk of serious exacerbations. This is not just oral steroid exacerbations. This is emergency visits, hospitalisations, or death. So this is seen even in patients with symptoms once a week or less. Now, 2 things. That group of patients, once a week or less, was always assumed from the very start of asthma guidelines to not need inhaled corticosteroids. And that assumption was never challenged. I discovered this sort of by accident in about 2014, and we did an analysis here of the START study that was published in Lancet in 2017. And you can see that here with patients who had symptoms 0 to 1 days a week, the reduction in risk of these serious exacerbations, just with a very low dose of inhaled steroids, was almost half. And in fact, the risk reduction was similar, independent of symptom frequency. And here are their symptom days per week. 90% of patients had symptoms 0 to 1 days a week throughout the study. So we have an assumption built into those early guidelines and into current WHO guidelines that some patients don't need inhaled corticosteroids, and that is just incorrect. The other problem with inhaled corticosteroid as that second step is that adherence is exceedingly poor. And, as I've explained, that's not at all surprising. It's just human behaviour that if you're given something that works brilliantly from your perspective, why would you want to take something else which doesn't necessarily benefit you? So in this systematic review, self-report, 35% of the prescribed dose was being taken, and with pharmacy refills, only 20% of the prescribed dose. Most people out there who are prescribed inhaled corticosteroids are not taking it. The result is that asthma is often treated either because of the patient's perspectives or by the health system's perspective as a recurrent acute disease. And that means burden to patients, the families, the health system and the economy, the risk of asthma mortality, and these cumulative risk of adverse effects of oral corticosteroids. So in 2019 in GINA, we made this fundamental change. So this is a change essentially on 50 years of practice that the treatment of asthma with short-acting bronchodilators alone is no longer recommended. So we said for adults and adolescents there, and we've since extended that to children 6 to 12 years. The reason was not so much the harm it wasn't related to SABA overuse. It was related to the extraordinary benefit that you could get with an intervention, not just with ICS taken regularly, but this time with a symptom-driven treatment that was acceptable to patients. This is the current 2023 GINA treatment figure for adults and adolescents, and this looks a bit daunting the first time you see it. I'm not going to go through it all in detail, but just to mention that this arrowed circle up here is a reminder that asthma treatment is not one size fits all, and it's not set and forget. There's this constant cycle of assessment, adjusting, and then reviewing the response to that. So I want to focus here on track 1, which is using as needed low-dose ICS formoterol as the reliever, as needed only in steps 1 and 2, and as maintenance and reliever therapy in steps 3 and 4. And the reason this is preferred, and has been for several years now, is that it reduces the risk of exacerbations compared with using a SABA reliever, and it's a simpler regimen. So I'm going to show you the evidence. So just some terms. So combination ICS formoterol is an anti-inflammatory reliever, or AIR. So if you're using it as needed only, you could call that AIR only. And then if you're using it with maintenance ICS formoterol, that's MART, or maintenance and reliever therapy. So the evidence, and we have 4 studies, 2 of them initiated by Richard Beeson here in New Zealand. So 4 studies totaling almost 10,000 patients with mild asthma. And the first line result is the startling one. So compared with as needed short-acting beta-agonist alone, just taking ICS formoterol for symptom relief reduces your risk of severe exacerbations by 2/3. So that's an extraordinarily large benefit. What about compared with maintenance low-dose inhaled steroid with a SABA reliever, which was at that time the standard of care? So the risk of severe exacerbations was similar in the 2 large Sigma studies and lower in the 2 open-label, more pragmatic studies, Novel Start and Practical. There were some slight differences in other outcomes. Symptoms were very slightly more, but a very tiny difference in ACQ of 0.15, where the minimal important difference is 0.5. Lung function very slightly lower. Airway inflammation by FeNO very slightly higher, but no progressive worsening over the period of 12 months. Now, patients use the as-needed inhaler on only 30% of days, so when you're calculating the cost of this treatment, you shouldn't be assuming that it's being taken every day by every patient, so you need to keep that frequency in mind for cost-effectiveness calculations. And then importantly, in Novel Start and Practical, analysis of outcomes for severe exacerbations and symptom control were found to be independent of baseline characteristics. So in particular, this works not just if you've got type 2 eosinophilic inflammation, but also in people with low T2 markers. It also is effective in people with low or high lung function and those who have a history of exacerbations and not. What has come since then are meta-analyses of the 4 studies, and this is the critical one, I think, when we're talking about cost-effectiveness and population-level change. So this is a meta-analysis of those 10,000 patients. So compared with as-needed SABA, the risk of ED visits and hospitalisations is reduced by 65%. That's a huge reduction in healthcare utilisation. And if you think about it in terms of the population attributable fraction, which we were hearing about this morning, most people with asthma in the community have mild asthma. And so this is a benefit that would be seen in a high proportion of patients. And then in the meta-analysis, even compared with regular daily inhaled corticosteroids, the risk of ED visits and hospitalisations was reduced by 37%. Now, moving on to maintenance and reliever therapy, so where you're using ICS formoterol as your reliever and also as your regular daily treatment. And this has been established for many years as being more effective than using either the same or a higher dose of inhaled corticosteroid or ICS-LABA with a short-acting beta-agonist reliever. And there's one study, I didn't put the reference there, sorry, showing that it's effective in both eosinophilic and non-eosinophilic asthma. So compared with the same dose of ICS-LABA, risk reduction of 32%, compared with a higher dose of ICS-LABA, risk reduction of 23%. In multiple studies, multiple pragmatic open-label studies compared with conventional best practice, again, a reduction in risk of severe exacerbations. And then this particular study shows that it's not just the inhaled corticosteroid component that reduces the risk. In this study, people were receiving maintenance ICS formoterol, and they had a reliever that was either a SABA, here in green, formoterol alone, here in blue, which reduced their risk of severe exacerbations, but the greatest benefit was in those who had combination ICS formoterol as their reliever. So progress since in the last couple of years, so as needed only budesonide formoterol has been approved by regulators in, I think that should be 48 countries. It's recommended in asthma guidelines in 32 countries and in Europe. And generic medications are available. So it's not one company's thing. Now, we deliberately embedded qualitative research in 3 of the randomised controlled trials. And what we found was that most patients with mild asthma prefer the as-needed combination over taking a daily medication. Some didn't. And in one of the papers by Juliette Foster as the first author, we described the sort of conversation that you can have to identify patient attitudes and beliefs. There's several cost-effectiveness studies, most for high-income countries, but this one published in 2021, which extrapolated from the 4 randomised controlled trials to Colombia. Now, I just want to think about this also from the patient's perspective and just a really pragmatic view of what this looks like to the patient and to the physician. So with the current WHO algorithm, you start with an inhaler that you tell the patient to take every time they need it or before exercise. And then if, contrary to sort of normal patient behaviour, they do actually come back to see you again, you say, well, you know, they're happy because it's working for them. You say, oh, you shouldn't be taking it that often. You should instead be taking this extra inhaler, this one I've shown here in orange. You should be taking that regularly twice a day, every day, even if you don't have any symptoms. And that will mean you don't need to use your blue one as often. That doesn't really compute. The second step in the WHO algorithm is you take more of the regular one, or you switch, and again this will be another inhaler, to a combination ICS-LABA, and that might be a dry powder inhaler. So you've got different inhaler techniques, and again you've got a difference in instructions. And then the next step, you add theophylline. And I haven't mentioned theophylline much, but it hasn't been recommended for a very long time because of its adverse effects. So SABA-only treatment, quick symptom relief, so the patients don't see the need for anything else. There's a high need for urgent healthcare and mortality with this step, and a cumulative risk of oral steroid side effects. There's that paradoxical switch in messaging between step 1 and step 2. And the ICS regimen requires the patient to be taking it regularly, so high cost, and they have to take it even when they have no symptoms. And multiple inhalers, sometimes different devices with different techniques. And this regimen has the highest carbon footprint, which is something that I won't go into, but is an important issue. And as I mentioned, theophylline is not recommended because of the high risk of toxicity. So look, essentially, this is what the GINA algorithm looks like, the track 1 algorithm. You have the same medication across treatment steps. You take it as needed for symptom relief or before exercise. If the patient comes back and they're using it a lot, then you ask them to take it regularly as well as needed. So there's no change in inhalers, and then you can increase the dose if you need it. But not many patients do. And the important thing is that your conversation with the patient at the start here is about symptom relief and risk reduction right from the time of diagnosis. You don't introduce the question of reducing risk when the patient has already been well established on SABA alone. It's the same inhaler device, so you've got a seamless transition between steps. And there's this very large potential reduction in healthcare utilisation and in the risk of these future adverse effects of cataract, osteoporosis, etc. And this regimen in this published study has the lowest modelled carbon footprint of any of the asthma regimens they tested. So with regard to the environmental effects, GINA published this paper in July in Lancet, calling for a focus on global access and patient safety in the transition to environmentally friendly respiratory inhalers, because the risk is, with the attention given to environmental impact in Europe, that supply and availability to low-income countries, low and middle-income countries, may be even worse than it is now. We emphasise starting with what's the right class of medication, because you can't choose between inhalers if you haven't decided which class of medication you need. And ultimately, the medication that's the safest and best for the patient is also the safest and best for the planet if you choose the right one. So thank you for your attention. You can see that I feel quite passionately about this because I'm drilled in evidence, and here we have evidence that is really substantially different from what we're currently recommending and currently practicing. So now the difficult part of how do we make it happen. Thank you.
Thank you very much indeed, Helen. And now Shami Jayasuriya, whose introduction is the same as it was earlier this afternoon. Shami is surprisingly still an academic GP in Sheffield and is doing a consultancy with WHO, and she's an NIHR lecturer in primary care as well. Shami's job is to now tell us about the role of clinical standards in the management of asthma. Thank you very much.
Just lower that down for me a little. Thanks very much. It's my privilege to be able to talk to you today about a collaborative piece of work on the role of clinical standards really for the management of asthma in low and middle income countries. I'm going to talk a bit through the background and rationale of this. It was very much a collaborative piece of work, methods, results, and a brief bit about conclusions. So, as you no doubt know from all the talks today, asthma is a problem across the life course, and as everyone has repeatedly echoed, the majority of deaths are occurring in low and middle income countries. And as we've had this amazing talk from Helen, we know that there's lots of clinical guidance out there from lots of different respiratory organisations. So we know there's good evidence, as illustrated by the previous talk, about what we should be doing. But we also know from Marie's talks earlier that actually access to inhalers in LMICs is very limited. And as we know from the stakeholder meeting, there is an issue about how applicable the current guidance is to low and middle income countries in line with what we've heard today. So we've got these great guidelines, we've got this great evidence base, and we know what we should be doing, and then we go to our cupboard to look at what we're going to do with our patient, and what we have there isn't what we need to deliver for the guidance that we have. And this is a very real dilemma, I guess a lot of you will be aware, and a lot of you may face in your day-to-day clinical practice in these settings. So there's this big gap here, and I guess I give this as a sort of example of how you might fill that gap. So, for example, a low-cost homemade spacer device has been shown to be non-inferior to a commercially bought spacer device in a Cochrane review. So perhaps there's a way of bringing some of this evidence to try and bridge this gap while we're waiting for a lot of ducks to align, as has been talked about earlier. So this is talking about, is there a role for this really, where you know what you want to do, there's some clinical guidance, but actually you have what you have, and what's the best you can do with what you have. So as I mentioned, this was a collaborative effort. So we reached out to 69 experts through the Global Asthma Network and through the union, and Philippa was instrumental in supporting in that. And there was a core team that developed some draft clinical guidance and standards, and a virtual Delphi process was followed. So we had a first and second round of responses with this guidance. So we had representation from 31 low and middle income countries. And what was very clear from the outset and from the first round was there was very high percentages of agreement. So we were already agreeing at 93% with the draft standards, and these were then honed to gain a 100% consensus in the final standards that were published. So you obviously won't be able to read all of the standards, but it's just to highlight that this is for where WHO essential medicines are accessible, and it covered identifying and diagnosing, managing acute exacerbations and long-term management, and the best evidence that we have now for what should be done. And I guess more importantly, it recognised the issue that I raised and offered some standards where actually you have no access to any of the WHO essential medicines. And as the statement says at the top of these guidelines, it's not an endorsement of primary use of oral medications for the treatment of asthma. And actually, what we're also very clear about in the standards is that it should be used to advocate through local inquiry. So I guess this sort of leans on Helen's talk earlier about spheres of advocacy, and that potentially trying to empower people to kind of, despite not having the right thing in their cupboard and trying to do the best with what they have, then trying to look to see if they can lobby to get what they need. So I just want to acknowledge all the Delphi participants who contributed to this, and the 14 core group members, but as well as Professor Kevin Mortimer, who's instrumental in the work. And it's been published in the International Journal of TB and Lung Disease. And just in terms of, with my WHO hat, I just want to highlight what Sarah Rylance also mentioned in her talk. So the WHO has a Global Alliance for Respiratory Diseases community on their knowledge action portal for NCDs. So this is a way for sharing content from the GARD Alliance member organisations. A lot of them, I'm sure you're familiar with, are listed here. The difference with this community is that any individual is free to join it and engage with the content. And what it tries to do is bring together in one site information from all those overarching organisations, and it has a calendar of events and a notice board. It does have a sign-up process to it, and if anyone's interested, I'll be around later today. But also I've just put my email on there if anyone wants to email me with more details about it. But the clinical standards are on there, as well as other stuff that's been going on. So that's all I was going to say today. Thank you for listening.
That's great, Shami. Thank you very much. Now, of course, Refilwe doesn't really need introduction. If she does need an introduction, then you haven't been paying attention. But Refilwe is a professor of pediatrics at the University of KwaZulu-Natal, co-chairs the Global Asthma Network with me, is a good friend and also my boss. Refilwe is going to tell us about the generating of evidence that's needed. Thank you.
Thank you very much, Kevin. Thank you for the introduction. So I'm going to just share some evidence or data that we're busy collecting around Africa, because I think we've been talking about the problems. We have identified the problems and we know what the problems are, and we're just trying to find some solutions. And I'll just share some of the work we're doing around in Africa to try to address these very problems that we've identified. These are just my conflicts. So I'm not going to even talk very much about this. I think the challenges have been identified, and I'll tell you about 2 projects that we're working on in Africa and South Africa to try to address these. I think we've seen the slide. We know that asthma is a big problem in low middle-income countries, and that's where all the deaths are happening. We've also seen some of this. I just wanted to highlight what the work I'm going to be talking about is trying to address. We are going to try to talk a little bit about data and hear how we can generate data in low resource settings, and also how to build capacity and try to find solutions. So these 2 projects that I've been talking about, the first one is called Chest Africa. And really what this is we're trying to create a disease observatory for chronic lung diseases. This is both for asthma and COPD. And this project has me and Kevin as co-PIs. And I'll just tell you a little bit very briefly about what kind of work we're trying to do. So really the aim of this is to create an African observatory for lung disease, and to do this really in a very scientific, independent, and data-driven manner, and to use very well-established methodology, to have governance as well as infrastructure, and really in the end to create a dashboard for respiratory diseases in Africa. This is something that's never been done before. We don't have very good data in Africa. So we're trying to, as a first step, use asthma and COPD as exemplars to see if we can create this kind of dashboard, observatory. So how we're doing this, we have 4 sites not going. They already, we have ethics, and some of the sites are already collecting data. So we're using the GAN methodology and collecting from 4 countries in Africa data from children as well as adolescents in the DR Congo, Nigeria, Uganda, and Ghana. So we use the normal GAN questionnaires. We actually, this is a very modified form. Instead of the 3,000 children per site, we'll collect 1,000 per site. We'll also be looking at exposure questionnaires. And what we're also doing additionally is doing some additional phenotyping of these kids by adding spirometry, pheno, and most importantly, I think from all of our discussions today, we're trying to collect some health economics assessments. So we'll be using the same methodology that Marie told you about to look at affordability and access to medicines in people who identify themselves as being asthmatic, so that we can really quantify what the cost is to the patients as well as to the health system for those who identify as having asthma. And using, because we're going to be doing spirometry in a huge number of people, we're also using AI algorithms to assist us to not only look at quality control of this spirometry, but also look at, hopefully, be able to use these tools for African populations later on. I'll just tell you briefly, we're also collecting data on COPD. This will be in 5 sites and in the 2 adult populations in Mozambique, Sierra Leone, Rwanda, Nigeria, as well as Burkina Faso. Now, what I didn't tell you, because you may be wondering why we have so many countries, is all of these investigators that I've showed you. We run a research methodology program across the continent. It's called the MECO program. Kevin was the previous director. Myself and Uju also are the current co-directors. So all of these people actually we source through our MECO program. So these are people that we have created a network with through running a research training program. And it's really building capacity in very early investigators to join this network to conduct research. So the COP data will be using the BOLD methodology, also collecting spirometry and pheno data to try to standardize the data collection, and this will be in 600 individuals per site. Now, in terms of the health economics data, which I've told you about, we'll be using the same methodology that Marie mentioned, and we really hope that this, in people that are diagnosed with both COPD and asthma, will be able to make a case to show what the cost is for the individuals, for the health system, and hopefully be able to advocate for better care for individuals. Now, the next study, the final study that I'll be talking about, I'm very grateful to Helen. Now you know what A is, because she's explained it so well. We're going to start a study, I think, in the next month. We've had all the regulatory approvals. As Helen has told you, the GINA track 1 really, the data is quite clear. Using an ICS formoterol is much better than using 2 separate devices to treat asthma. Now, the data in young children is lacking. There's very clear evidence in adolescents that the strategy works very well. And in the study, we aim to see whether this approach, using the anti-inflammatory reliever, which is ICS formoterol, compared to the standard of care, which is the 2 inhalers, would be a strategy that would be beneficial in younger children between 6 and 18 years. So really a primary endpoint of the study is to compare exacerbations between the 2 groups. This study is only happening in South Africa, and I'll be telling you a little bit more about the site, which is what is slightly different. We also have a number of secondary objectives. Again, very importantly, our Department of Health is not interested in any drug until we tell them it's cost effective. So we have a PhD student who's also going to be looking at the cost effectiveness of these 2 approaches. So we'll be collecting data from the patients themselves, from their families, from the health system, to see what the economic costs of switching, comparing the 2 study arms will be. And then we also have some other secondary objectives, lung function as well as quality of life between the 2 study arms in the study. So we'll be randomizing just over 1,000 children into the intervention arm, which is the ICS formoterol, as well as the standard of care arm, so just over 500 children per study arm, and we'll be following up these children for a whole year. This is Mobile. She's a health economics PhD. She'll be looking at a number of health economics costs, as I've told you, at the facility level, individual levels, as well as costs to the health system, to see whether there's any difference in the 2 study arm in terms of costing. Now, what is slightly different about the study is we were very brave. Normally we do these trials in a nice urban center where I'm close to the population, but we'll be doing this in a rural center, which is in northern KwaZulu-Natal. This study will be housed at the African Health Research Institute, which has a clinical trial site in northern KwaZulu-Natal. So it's very different. It will be a very rural population. You can see the kind of houses that some of these individuals will be sourced from. But this is a very well-established trial site which has good health information systems. We have nurses that actually go into family homes. This population is actually very well characterized and has been studied for over 20 years. So it will be very interesting because here we're actually doing the study at a primary care level, at clinics. So we have research nurses that are based at the clinics as well as medical officers, and this study will be done at the primary care level and not in a fancy quaternary hospital. So in conclusion, I think I just wanted to say, I'm not ashamed to say now GAN is an excellent platform. I'm just selling ourselves, and has really shown how if you network, you can really generate excellent data. And we hope that using the same type of platform, we can really generate data in other continents and other LMICs with example, the kind of work we're doing with East Africa. And I think, as we've seen today, health economics, money is what policymakers are interested in, and it's quite important that we do generate this data so that we can actually advocate to our health systems to actually fund the right drugs for our patients. Thank you very much for your attention, and I really would like to acknowledge all the sponsors and funders that have supported the work.
Fabulous, thank you, Refilwe. So we have one talk left, and then a little demonstration of the on-demand and online discussion forum. So I get to introduce myself. I'd like to thank me for inviting me to give this talk. This is going into a slightly different place. So I'm Kevin Mortimer, you might have gathered. So I'm a professor of respiratory medicine working with Refilwe at UKZN. My main job is as a clinician. I'm a respiratory consultant at Aintree University Hospital in Liverpool, and I'm co-chair of the Global Asthma Network. So this talk is about the burden of vaccine-preventable diseases in people with asthma and the importance of improving access. These are my disclosures. I'd like to acknowledge the support that both AstraZeneca and GlaxoSmithKline have given towards the GAN Symposium, and sponsorship from GlaxoSmithKline for this one. I've had some help from the vaccines team there in putting these slides together for today. Firstly then, lower respiratory tract infections are major causes of global morbidity, mortality, and economic disruption. They're the fourth leading cause of years of life lost, cause many millions of hospitalizations around the world, and cause major costs to individuals, households, health systems, societies. And we know that infections are major drivers of respiratory disease exacerbations, including asthma exacerbations, both bacterial infections, but particularly viral infections. We know that people with underlying medical conditions have high mortality rates during influenza outbreaks, including people with asthma, and that these are age-related. People with asthma are susceptible to invasive pneumococcal disease. This is summarized here on this slide, several studies combined in meta-analysis. The story is a bit different for COVID-19, where asthma doesn't appear to be a risk factor for this disease. Some features of the nature of asthma that might explain this. Some uncertainty regarding patients with asthma who are on oral steroids who might be at increased risk. But it illustrates that not all respiratory infections have the same impact on people with asthma. Respiratory syncytial virus is, we've heard about this morning in relation to children. This talk is really focused on adults. And it's increasingly recognized in adults that respiratory syncytial virus is a problem. If you pick this up and you've got asthma, you're much more likely to end up hospitalized. It's an increasingly common cause of, or increasingly well-recognized cause of asthma exacerbations and hospitalizations. Something we might not immediately think of as being associated with asthma, herpes zoster. So there's immunological rationale for why people with asthma might be at increased risk of herpes zoster, summarized here, including that the adaptive immune response in asthma is skewed towards a T helper 2 versus a T helper 1 immunity, with T helper 1 being most important in preventing reactivation of varicella zoster virus. And of course, people with asthma are often treated with corticosteroids, which themselves can increase the risk of herpes zoster. This can be a very disabling condition, causing lots of pain and other complications. There's a bit of evidence summarized here from a series of studies that there is an increased risk of herpes zoster in people with asthma, a fairly consistent 20 to 30% increased risk. There isn't a meta-analysis of these data yet, and I think it would be useful to have this. And this slide illustrates the impact of herpes zoster vaccination. The slide in the middle shows the impact of herpes zoster when this was introduced in Australia in the 70 to 79 age group, showing a reduction in the incidence of herpes zoster without any impact on the younger and older age groups where vaccination wasn't introduced. The vaccinations recommended for people with lung diseases, including asthma, vary from country to country, from organisation to organisation, and the ones that I've talked about here are summarised. As of course we're in New Zealand, this is just a little summary of the current recommendations for adult vaccinations for people with chronic respiratory diseases here. This illustrates the point that vaccine coverage varies widely around the world between different WHO regions in relation to different vaccines. This map makes this point in relation to flu vaccination. This could just as easily be one of the slides that we'd seen before of world maps relating to inhaled corticosteroid coverage, because some of the stories are the same. One being there are many countries where there are no data. Those countries are mainly the low and middle income countries. And where data are available, there's much greater coverage or availability in the higher income countries versus the lower income countries. There are many barriers identified for uptake of adult vaccinations. Some of those are summarised here. Most of them could equally apply to adoption or uptake of inhaled medicines for asthma too: access, cost, poor health literacy, efficacy, safety concerns not being recommended. Here are some recommendations from Barbara Yorn and colleagues about how to try and encourage and support routine immunisations in clinical practice for adults with respiratory disease. Again, we could largely replace the word vaccine with inhaled corticosteroids or inhalers here. So raise awareness, know the vaccine recommendations for your patient group, start small, focus on 1 or 2 vaccines with high relevance, review vaccine status, carry out at least an annual review, expand your vaccine community beyond clinics, hospitals and long-term care facilities, give strong vaccine recommendations while enabling patients to make their own decisions, co-administer vaccines wherever possible, and give clear instructions on where to get them. Then lastly, what can we learn from Gavi, the Vaccine Alliance? And this is one of the reasons for having a talk about vaccines here today. So Gavi's goal is to help countries build sustainable immunisation systems, provides vaccines against 18 diseases. It's helped vaccinate several millions of children and prevented millions and millions of deaths. In Gavi-supported countries, basic vaccine coverage has increased substantially, and by way of the Gavi approach, several countries have also transitioned away from having Gavi support. It's an innovative model. If only we could achieve for people with asthma in relation to inhaled corticosteroids or ICS for Motorol, what Gavi has achieved for vaccination programs, would go a long way towards achieving the Global Asthma Network's vision of a world where no one suffers from asthma. Thank you. So now for something a little different, and I'm hoping the website we loaded earlier might appear magically. It's looking good. because I'm not pressing anything. So what everybody is going to get who has registered for this in-person meeting, for the live stream, and for the on-demand is access to this smart lab. And although I logged into this earlier, it's logged me out. So everyone's going to get an email with their login details, which will be their email and an easy to remember password, which I think is that, which will then take you to this smart lab. So this is, the idea of this is it does two big things. One is it provides all the on-demand content. So in this bit, view presentations, there'll be access to all of the talks that we've gone through today, edited and professionally curated. And it'll look something like this. So the talk will be available here at the top. This one's there already because this is the one Sarah Rylance recorded for us. Here there'll be the Nifty Fox graphic giving a visual abstract summary of the talk, and then there's the abstract. And at the bottom here there's an opportunity to start a discussion. So this is that's the on-demand content, and this should all be available from the 15th of February. But the really innovative bit of this, and where the big opportunity lies to discuss and do something more than just talk about the problem, is to go into these workspaces that we've set up. So these are basically, there's 12 of them. You can choose none of them, you can choose all of them, you can choose one that grabs your fancy, that you might want to engage in a discussion with others within the Global Asthma Network. They're all going to look fundamentally the same behind these tiles. So I'm going to choose this one because I want to advertise it. So engaging people with lived experience of asthma. And so in these, there'll be a little introduction to it. So this one says, please join the discussion about engaging people with lived experience of asthma through the work of GAN. There'll be some resources. So in this case, we've got the Global Asthma Report, the paper that Sai summarized earlier, the New England Journal of Medicine evidence one, and there's a paper from Marie there. And the resources will all be nicely accessible, so if you want to see this paper, you can click on the link and get to the website for that. And then I want to go, now it's showing off. Right, here we are. And then there's opportunities for all of these. You can add comments here, you can start a discussion here, but even better is to go into this section which is called Join the Discussion. So here, this is a place where anybody can add a topic for discussion. So for this, we might want to say something like, how can we work with WHO on this? And then WHO co-working might be the description of this. And then we'll click next and we'll save it in the folder, which is this one about engaging people with lived experiences. We'll add the discussion, and then anybody can then pile in. And if I say something and then somebody else says they strongly disagree, that's a load of nonsense, like usual, Kevin, you can tag me, and then I'll get a message to say that you've told me, you've sent me a message, and I'll respond respectfully to the challenge. So this is something we haven't tried it before. It's maybe a bit innovative, but we want to try and keep the discussion alive and do something more than just discuss. That's why they're called workspaces. The idea is we do something, or we create something together. So there's this one about engaging people with lived experience with asthma. There's the next next global asthma report. We've had some discussions already that we think that those two things could well be the same thing. So the next global asthma report is likely to focus on patient voices. And I suppose the last thing to say about this work and the paper that Sai took us through, the New England Journal of Medicine Evidence one, is that we reckon we should do this, get patient stories for as many of the WHO member states as we possibly can, and use that as the core material for the next global asthma report. So this is an invitation to pile into the Smart Lab and add your name to being interested in being one of the people that gets one of these stories. So that is where we're now going to go, hopefully, from the 12th of February. Please do get involved, even if you don't do much or just have a little thing to say about one or two things. It will just help get the conversation going and help keep the Global Asthma Network collaboration and discussions going. So that's that bit. Hopefully that's going to work well. And then the last bit is concluding remarks by me and Refilwe. And we need Karen and Lewis's help here. I think Karen is going to get something. And while they're doing that, we now need Ines and Philippa to please join us. You're looking puzzled, but that's the nature of surprises.
You'll be summoned to the front.
Stuck down here.
So obviously it's a big moment in time. We've all come to New Zealand for this event for several reasons, but one of the really big ones is to say a heartfelt thank you to both of you for your friendship, for your incredible work with the Global Asthma Network. I think before I'd even left school. It all started.
I'm on my walking
and of course, we could, Refilwe and I feel very privileged to be now taking on the reins of being the co-chair. But we obviously couldn't finish without marking the moment with some gifts and these words of thanks. So these people have lined up.
I'm coming over by Philippa for moral support.
to say thank you.
Oh my goodness.
And then you also have
Oh, thank you very much.
You're very welcome. Oh, this is a compliment.
If you want to hear him talk. I haven't given this to a proper hug either for me.
So I think before we have a flood of tears, it was just for us to say thank you so much to Ines and Philippa. Although you're handing over the reins, we hope we can come back and visit you in Auckland again. And we hope that you don't ignore our emails, which I'm sure you won't, when you ask for help. There may be some cries of help in between, but we really, really appreciate everything that you've done for asthma, for us as individuals. I think your kindness, your collaboration, I think everybody knows the both of you. And every time I used to get an email from Philippa, I knew, yay, I'm part of the group. So thank you so much for all you've done for us, and we really appreciate it. And I think we couldn't have ended this without saying a huge thanks to both of you. And I hope that you get to do your swimming and your hiking, and you can also get some rest and stop worrying about all those collaborators sending you emails, Philippa, and to please get some rest. So thank you so very much to both of you.
You can have the last word.
I just feel so humbled to have been part of such an extraordinary teamwork. We had no idea what was going to happen when we started, and it's all about, as you've heard, it's just all about working with people, and it's been a very rich and rewarding and wonderful and humbling experience. And what I would like to say is we've had the global steering group meeting this weekend, and the Global Asthma Network is continuing. It's refreshed. It's got some fantastic people involved. Some are old and some newer ones, and we think that there's a great collaboration and research plan and with outcomes ahead. So I think that this is a transition moment. It's a retirement for me tomorrow and for Philippa at the end of February, but it's really a transition moment for the Global Asthma Network, and I think it's in great heart and has a great future. And so thank you very much for everything, everybody, everywhere.
Absolutely, yes. I echo those thoughts. I'm going to break down and cry. I started off 35 years ago with 1 year's funding. And each year the funding miraculously came to fruition, and it's been an incredible journey. And thank you to the ISAAC Steering Committee and the GAN Steering Group, and the collaboration has just been incredible. I've met some wonderful people. I've had some amazing experiences, some wonderful trips overseas, but it's the people. It's the memories and the people, and it's just the Global Asthma Network, as Anna said, is going forward in the most wonderful, strong hands, and that's really pleasing to be stepping down from the steering group and retiring, knowing that the Global Asthma Network is forging ahead. So thank you, everybody, for the contribution. It's been wonderful. Thank you.
I'd just like to say also thank you for these gifts, but also just being part of the ISAAC and now GAN has just been a tremendous personal gift to us, just in terms of our lives. It's just been a wonderful part of our lives. Yeah, it's been. So thank you very much, everybody. Thank you.
Thank you, everyone. I think we can now go and have a great afternoon. Thank you. Thank you for your attendance.